very much. Village boy like me, I should have turned it on. Thank you so much, sir. All right, so good morning. I know we said we'll start this off at 10, but certain things have to happen before then, so that at 10 on the dot, I can call on the next speaker to take us on what we need to get done. All right, so please, can we be on our feet to take the national anthem, Nigeria? I would not even attempt to sing because that would send you guys out of the room. So we'll just stand in honor of our country and listen to the soundtrack.
On trendybeats.com.
Thank you so very much. Please do have your seat. Thank you. Thank you so very much for making it out early. We are committed to working with you to stick to time. We have a huge responsibility before us today, and we are all very busy professionals. I would shortly be calling on my country director to do the honors regarding the welcome remarks, but before I do that, I would just want to acknowledge the presence of every single one of you in the room. So we're all very important people. The purpose of our gathering is about the pre-service health training institutions. So forgive me, I'm a contrarian, so I would not be starting from any particular order. I would want us to put our hands together for the students in training. Please, let's put our hands together for them. So because in the end, everything we think and do is about providing the environment and the support for these young ones to go through school and become the best that they can become. I also would not want to spend any time in jail, so I would not want to get into particular names and individuals. So I would just quickly do a run through of the organizations that we expect to be in the room. And if you're here, just wave your hand and acknowledge that you're here. Do we have any representatives from the State Primary Healthcare Development Agency or the National Primary Healthcare Development Agency? All right, I would take that as a no. Any representative from the state's ministries of health? Thank you so very much. We appreciate you. Any representatives from the state ministries of higher education? Awesome. Thank you so much. Any representative from any of the numerous pre-service health training institutions that we support across states? Thank you. Thank you so much for making it over. Would we have anyone representing the National Military Council of Nigeria? Thank you so much, sir. I said I wasn't going to mention it, but my digital registrar. Thank you, sir. Yeah. I haven't mentioned names, have I? Community Health Practitioner Registration Board of Nigeria. Any representatives? Registrar, sir. Thank you so much for making it over. The FCT Health and Human Services Secretariat. Any representatives? Not yet. Nana Girls and Women Empowerment representative. Dr. Fatima, thank you so very much, ma'am. The National Board for Technical Education. NBT. Greetings, sir. Thank you so much for making it over. National Universities Commission. No? Okay, great. The West Africa Examination Council. Thank you so very much, all the way from Lagos. We appreciate you. The Joint Admissions and Matriculation Board. JAM. Thank you so much. I love your confidence. You're not even afraid that some students can walk up to you and a great one. Thank you so much for making it over. The National Primary Healthcare Development Agency, I've said that before, we don't have yet. Okay, I think So now, I haven't gotten any jobs, any new jobs, right? I love what I do. So can we have representatives from the USAID? Let's clap for them. Thank you so very much. So introducing you guys is like way above my pay grade. So I'm going to leave that to the person who should be able to do that accordingly. Can we have the mentee come up, because I need to give certain instructions about how we can best utilize this event. So can we broadcast the mentee meter page? And while that is coming on, now I'm giving you the authorization to go on your phones and open your browser, not Facebook or Big Brother Nigeria, please. Your browser, any browser that, and just punch in menti.com, menti.com, menti.com. I know it's not likely one of the bookmarked pages. Thank you so very much. Okay, great. So where would this be found? No. Are we there on menti.com? Good. All right. So it's asking you for a code. It should be asking you for a code. If it's not asking you for a code, you're not on the right spot. If it's asking you for a code, it is. Okay, great. So now let's find the code. Can someone help me with this? All right, so the code is right there, even with my glasses. Pardon me. So 7512. I don't know if people from outside Nigeria are conversant with the slang about village people. We didn't register any one of them, but we think they're in the room. So the code is 7512-2172. 7512-2172. Can you put that code into the space? If you're in, can I just see you signify? Awesome. The students are there. Oh, brilliant. Everybody is, almost everybody. We have like 50%. So 7512-2172. And you'll be able to follow this. If you're also joining us virtually, please do that. Go on any browser, type in menti.com and put in the 7512-2172 code, and you'll be able to follow all that we're doing. And so a couple of years ago, I fell in love with this saying about the illiterate of the 21st century not being someone who is unable to read or write, but being someone who is not willing to learn, unlearn, and relearn. And that's why we're gathered here this morning through the afternoon to think about the systems we have created, to think about the results that we're getting, and to ask ourselves very important questions about what we can do differently to get the results that we need to get. And with that said, we're almost 7 minutes behind schedule. I have the honor of bringing to you the one and only. We call him, so the Nursing and Midwifery Council guys call our registrar digital registrar. We call our own country director artificial intelligence plus machine learning plus all the new works country director, Dr. Andy Omoluabi. Let's make him welcome, please.
I can't stop smiling. Good morning, everybody. And thank you, Emmanuel, for that introduction. But let it be clear, whether AI or artificial learning, he's real. He's real. He's somebody you can see and touch. So, good morning, everybody. I am really quite excited to see the people in the room. And I know that when Emmanuel was doing a quick check on those guests we have, some of them were not represented. I know that they will be here in the course of our meeting. So I'm really excited to see high-powered delegation from the states represented by the PAMSECs, people from JAM, WAEC, the registrars, and a very strong delegation from the two regulatory bodies that we work with, NMCN and the Community Health Registration body. We also have very good orgas from USAID. We have heads of schools. We have our implementing partners who we work collaboratively in the states that we work here. We have IHP, we have APTS, thank you very much. We also have a representative of the Health Commissioners Forum as part of our gathering today. So I'm really delighted to be here, as I mentioned earlier, to welcome you to this very important dialogue on the production of critical primary health care human resources for our country. We've been in operation now as a project for 3 years, and we thought enough of doing the backroom kind of things. Let's begin to bring the issues to the fore, and this is one way that we are doing it. As it says, it's an annual dialogue. We're starting with this one this year, and we're going to learn a lot of lessons from it and be sure that for the next couple of years, we are going to be having this dialogue and looking at different themes as we go along. Well, as you all know, human resources for health are essential for strengthening the country's health system. In Nigeria, the primary health care workers, such as nurses, midwives, and community health extension workers, play this very critical role. The basic but essential health services that they provide to particularly women and children are pivotal for improving health outcomes. I'm sure all of you will agree with me on that. Our country has, however, continued to face several challenges in producing enough human resources for health to meet the needs, especially at the primary healthcare level. These challenges are well known to all of us in this room because we are all key stakeholders on that subject area. But just to itemize some of those key challenges, which include shortages of qualified tutors and trainers in the pre-service health training institutions, learning environments that are inadequate to produce 21st century compliant healthcare workers, weak capacity to adapt and deliver the various training curricula, even though we've worked with 2 of the regulatory bodies to revise various training curricula that they use. We still see challenges in the adaptation and delivery of the curricula. And we have some interventions around that, which we will talk about in the course of our dialogue today. And of course, there are issues with admission. That's why we have representatives of JAM, WAEC, and we're just told that there's another body which we've missed out, but for the next iteration of this, we'll be sure to invite them. Well, the dialogue, which is the first of its kind, I like to believe, has been designed to gather people like yourselves to discuss these challenges and identify practical and sustainable solutions for improving the production of this critical PHC, human resources for health in our country. On behalf of the Health Workforce Management Consortium members, I would like to thank USAID Nigeria for the Health Workforce Management activity as part of USAID's support to overcome Nigeria's HRH challenges. I also would like to recognize the various institutions that we are working with for granting us the permission to collaborate closely with you. Without your permission to collaborate with you, we won't be able to get anything done. So we're really, really appreciative of your willingness to work with us. We, the implementers, my team and the consortium members do consider ourselves fortunate to be part of the Health Workforce Management activity. And we call ourselves HWM for short. We've had all iterations, HWM, HMW, but it is HWM activity. Is an exciting initiative that is gradually but surely chipping away at the huge HRH crisis that we face as a country. I am confident that this dialogue will be a productive one, and like you, I am eagerly looking forward to harvesting sound ideas and recommendations that will help us advance the production of this critical health workforce. Distinguished ladies and gentlemen, you're welcome and thank you.
Some of you are acting like someone would ask you to pay for every clap you're making. So while I was speaking, I actually felt, when I looked at the video, I thought it was me at some point. I was like, okay, I'm not wearing my, oh, sorry, it's Dr. Andy, yeah. Okay, so thank you so very much, Dr. Andy, for the amazing work that you do. Right now, I'm meant to bring up a very important person. We're all very important. Animal farm, right? All animals are equal, but some animals are more equal than others, right? But before we do that, I'm sure for those of us who are very security conscious, we're already looking for where we could escape from, you know, and all of that. So we'll bring up a gentleman who would speak to us about the security setting and all of the logistics around here. Can we have the gentleman who, thank you so very much. Let's put our hands together for him.
Good morning, participants. My name is Johanna Damu from the Safety Department of Abuja Continental Hotel. I'm here to tell you what to do during your event for in case. Actually, if you want to locate the restroom right from the hall, you go out and you see by your right, you see a security man standing. You ask where the restroom is. It's left for you to use which one is convenient for you to use. And actually, we don't expect any alarm. But for in case, if there's any alarm that exits for 3 to 2 minutes, please don't panic. We have emergency evacuation team that they are here to come and tell you what to do. So please, once you hear the alarm, please don't panic. We don't expect any emergency, or if there's any emergency in the hall, please, we have 2 exit doors linking to our muster point. That's where you rush to, but by God's grace, nothing will happen. Please, the important one, which is very important to us and you, your belongings. I have some people, they want to go out, they'll keep their laptop on the seat and go out and come back. So please, we don't encourage that. For in case you are going out for your tea break or lunch, go along with your phones and your laptop. We don't want to record anything. I don't see my handset, I don't see my phone. So please and please, help us and secure your laptop. But for in case you are leaving your seat and you know the person close to you, that once you go and you leave your things, if you don't come, you can reach that person. Please, I'm advising you to please keep it for him. And secondly, very, very important, the management are very, very secure on that, on the items you have. Come with your handset and your phone. To us, is very, very important to you. That's why we don't accept anybody to keep your things careless. And you, when you come to the program for another mission, remember, as you are sitting down, camera is watching you, it's recording your movement. For in case you have another mission, not to come and listen to the program, please, if you have that mission, please keep it outside the gate. Thank you very much. On behalf of the management, we are wishing you all the best of the program. Thank you.
Thank you, Mr. Johanna. All right, so now I'll be bringing to the stage Meko McKay, who's the Acting Director, Health, Population and Nutrition Office of USAID. Please let's make welcome warmly. Please drop your phone and put your hands together. Thank you.
Okay. So good morning, ladies and gentlemen. Observe all protocols. I can see from the agenda that you were expecting a man, but in fact I'm here, the Acting Office Director for USAID. And I was just having a conversation with our government representation from Bauchi State about the importance of women. You know, it's a man's world, but it's the women who are the engine that are keeping it running. So I'm happy, very delighted to be representing women and also USAID to offer these remarks. For the Human Resource and Health Policy Dialogue, which is organized, as you know, by the USAID-funded Project Health Workforce Management activity in collaboration with the Nursing and Midwife Council of Nigeria and Community Health Practitioner Registration Board. Unfortunately, Nigeria shoulders over 34% of the global burden of maternal death and is now the world's highest contributor to the death of children under the age of 5 years as well. According to the Lancet from 2018 Global Health Commission report, the poor quality of health is now a bigger barrier to reducing mortality than insufficient access to care. And the United States government, through USAID, is changing this reality with the health workforce management activity in partnership with the government of Nigeria at the national and the subnational level with relevant professional regulatory bodies and pre-service health training institutions by improving the quality of pre-service training for health workers. Fostering an environment that is conducive to learning is critical to pre-service training of health workers. We know that a positive learning environment and good tutors are essential to improving primary health care, as they ensure students are fit for purpose and fit to practice in the health workforce. Good tutors are capable of fostering an environment that's conducive to learning and are created through the deliberate formation, adoption, and implementation of sound policies. So today, USA challenges the government of Nigeria at all levels to make additional investments to improve the quality of pre-service health training. We call on the leadership of the pre-service health training institutions to improve accountability and prudence in the management of resources. And finally, we encourage students and tutors to demonstrate positive behaviors that promote supportive and collaborative learning. A viable, committed health workforce is critical to USAID's goal to contribute to drastically reducing preventable maternal and child deaths in Nigeria. USAID is committed to continuing the good work with partners to build sustainable solutions to health workforce challenges that are stunting Nigeria's progress. So I thank you, the organizers and all the participants for coming, and I wish you all the best as we deliberate over the course of today's events. Thank you so much.
Thank you so much, Mieko. And just so that you know, I'm not going to be shaking any other person. I'm taking this to the bank right after this meeting. So yeah, we need to test the Mentimeter platform again. So I'm sure you're used to this kind of gathering where we have people come up to give goodwill messages. I mentioned to you earlier that I'm a contrarian, so I'm not going to be calling anybody yet. We're going to be doing that much later. So I'll be calling on the next person who's going to be walking us through the overview of the health workforce management activities intervention in the pre-service health training institutions. And I also felt that this was kind of like above my pay grade, but can we make welcome Jason Wright, who is the Principal, Associate, and Health System Strengthening Lead at Bayern Global, and the Home Office Program Manager of the Health Workforce Management Activity. Let's put our hands together for Jason Wright. And don't stop clapping until I tell you so. Thank you. You're welcome, Jason. Sorry. Thank you. So, is that clear enough for you? Yeah. Okay, so we'll just move from here. Okay. Thank you, sir.
Thank you very much, Emmanuel. And Miko, thank you very much for your call to action to start us off today. We appreciate the fact that so many of you have decided to participate today. We appreciate the representation both from the federal and the state and even the regional level as well. This is a very broad and deep partnership, and we very much appreciate the support from USAID for the work that we do. Banyan Global as the prime, and then our partners, Apt Associates, the Institute for Healthcare Improvement, and Salina Health as well. I am going to present the overview of the HWM activity for those of you that might not be as familiar with it. It is a 5-year, $19 million activity that is being implemented at both the federal and the state level. And we do work in 4+1 states. I'll get into those states a little bit later. We are trying to be responsive to the National Strategic Health Development Plan, as well as the primary Area 9, Human Resources for Health in particular. HWM does align with the USAID Nigeria Country Development Cooperation Strategy, and in particular, thank you very much for that, the Development Objective 2, healthier, better educated population, and intermediate result 2.1, improved health outcomes for priority populations in targeted areas. So the HWM activity has two dual purposes. One, to support the establishment of a cost-effective, well-trained and motivated health workforce, particularly in targeted rural and remote areas, and to contribute to greater health systems responsiveness and improved health outcomes, especially among women and children. I mentioned our consortium partners, again, APT Associates, IHI, and Selena Health. We do appreciate Selena Health in particular as a Nigerian partner, and really appreciate the opportunity to work through grants under contract to work with other Nigerian partners as well. So you'll see here the intermediate results and objectives. We do have 4 intermediate results. First is the quality of healthcare worker training improved. IHI is the lead for this intermediate result, and we're trying to strengthen pre-service training, learning environment, and the in-service training program. The second intermediate result is human resource information systems improved. APT is the lead for IR2. And we're looking to support the building of robust HRS to keep track of the recruitment, deployment, retention, and continuing education of health workers. IR3 is governance and management for health workforce improved. Selena is the lead for IR3, and we're attempting to strengthen the governance and management of the health workforce. And lastly, IR4, interventions to improve health worker retention, developed and adopted. So Banyan Global has responsibility for IR4 and then across all 4 IRs. And we're looking to support the conduct of HRH research to improve HRH practices and retention mechanisms. I mentioned the 4+1 states before. We implement in Bauchi, Ebonyi, Kebbi, Sokoto, and the FCT. And the next few slides will go through our target beneficiaries. Ultimately, our beneficiaries are the populations accessing integrated people-centered health services and public health facilities and enjoying improved health status, obviously looking to increase the production of health workers in particular. So the frontline health workers, and we're focusing on 3 cadres, nurses, midwives, and community health practitioners. We work with the pre-service health training institutions, both public and private. We work with the Federal Ministry of Health and the National Public Healthcare Development Agency, especially its HRH division. And then at the state level, we work with the state ministries of health and the state public healthcare development agencies. Work with the regulatory bodies, the Nursing and Midwifery Council of Nigeria and the Community Health Practitioners Registration Board of Nigeria. And then at the local level with the local government authorities, local government area level health authorities and the lower level health facilities. We do collaborate very closely with other USAID health population and nutrition implementing partners and implementing mechanisms, including Breakthrough Action from Johns Hopkins University CCP, the Global Health Supply Chain Procurement and Supply Management Project from Chemonics, the Integrated Health Program from Palladium, and the Momentum Country and Global Health Global Leadership from JPIGO, as well as the PMIS project, the President's Malaria Initiative for States project, on which we're a sub to Management Sciences for Health. So the last few slides, I'll get into some of the results we've been able to achieve over the first 3 years of the project. So we are focusing on improving the pre-service health, pre-service training learning environment. We're looking to make the training curriculum more problem-solving oriented in the face of quality of a rapidly changing healthcare delivery space where quality is certainly an issue. And we've been pleased in particular to revise the multiple curricula for nurses, midwives, and community health practitioners. We've improved the capacity of tutors to deliver these curricula. We've helped the programs at the various pre-service health training institutions achieve full accreditation or reaccreditation. We've increased the teaching staff development and retention, and we've increased the number of graduating students overall. So you see here that we do take a systems approach to what we're doing with the tutors, with the college management committees, and with the operating environment as well. I'm going to turn around for this just because the type is very small on the screen I'm looking at, just to be able to go through it. So you'll see here, we're working to make sure that the tutors themselves are able to better implement these curricula. We want to make sure that they have access to electronic resources. You'll see in particular, we mentioned EBSCO, which is an e-library, which provides tens of thousands of resources to the tutors to improve their teaching. We have initiated the Tutor Connect program, where we have monthly sessions for the tutors to help improve their understanding and ability to implement curricula. We've started the Tutor Fellowship program. We have a tutor twinning program, and lastly, we're looking as the end result to make sure that their knowledge and skills are improved. The college management committees have been an opportunity to work with the pre-service health training institutions to consolidate their needs and to make sure that we're trying to meet them as effectively as possible for both the public and the private institutions, and working both with the public sector and increasingly with the private sector to make sure that we can meet the needs. We've had some examples of building new residential facilities, new classrooms, new equipment as well for the institutions. And it's really been inspiring to see that we have upwards of 20 different private sector enterprises which have shown interest in providing support to pre-service health training institutions across the country. You'll see that we mentioned these institutional strengthening plans. So these are really a way to, again, consolidate all those needs in one place, so they're very clear both on the supply side and the demand side in terms of what is needed and what is available to try to meet those needs. And in the end, we want to make sure that, one, the CMCs are strengthened, but more importantly, that the pre-service health training institutions themselves are strengthened through the process. Lastly, talking about the overall implementing environment. We are looking to have support for resource mobilization. I did mention we've had upwards of 20 private sector enterprises express interest, and we've had a half dozen of those actually provide some resources to the institutions so far. We are advocating with both the federal and the state governments to make sure that in the annual budgets there is as much support as possible for the pre-service health training institutions. And lastly, we're hoping that we're raising awareness and increasing support for the pre-service health training institutions across the board. The last two slides will look at some of the results we've been able to achieve so far. I mentioned before the EBSCO e-library, so we have provided access to these tens of thousands of resources to tutors and students in pre-service health training institutions across the 4+1 states. We have provided partial scholarships to more than 600 female students in the 4+1 states, and we have improved the student examination pass rates overall. With the tutors, they've also received access to the EBSCO e-library. We've improved their capacity to deliver the curricula. We have started the Tutor Connect program, where we've had hundreds of tutors not only from the 4+1 states, but the word of mouth has started to have tutors from the other 32 states participate as well. Looking forward to continuing to build on that. It is a Zoom-based platform where we deliver subject matter expertise, and as I mentioned, we've had hundreds of tutors participate so far. And then lastly, we've increased the quality of continuous professional development across the board. And then lastly, in terms of management and the regulatory bodies, with management, we have provided accreditation support. As I mentioned, we're looking to make sure that the programs are accredited or reaccredited. And this support includes self-assessments, mock accreditation exercises, and the procurement of learning aids. And then we've mobilized resources both from the public and the private sector. And then with the regulatory bodies, we have revised the training curricula for nurses, midwives, and community health practitioners. And for community health practitioners is actually across multiple categories, the junior community health extension workers, the community health extension workers, and the community health officers. We're working to revise the standing orders for community health practitioners, and we're hoping to digitize those as well. We're looking to domesticate the curricula, and lastly, to improve the quality of CBD programs overall. So with those results, hopefully that provides a good foundation for the rest of the day. Again, very much appreciate the support of USAID for the work that we do, and thank you all for your active participation today. Thank you.
So how many times do we have to give the rules about clapping for people until Emmanuel says stop? Thank you so much, Jason. So truth is we're all getting older than we want to, right? So I'm struggling to see what's going on that screen. So we're going to be making some readjustments so that people who come on stage will be able to have access to that screen. But while that will be going on, I just wanted to let Jason know that I'll be approaching him for some voiceover gigs, right? The quality of his voice was quite intimidating. I felt like going to take some cold water so that I can sound baritone like he does. The next thing on our agenda would be the keynote speech, but I would need for Dr. Fatima to be able to see our slides very well. So guys, if we can make this happen right now. But while we're doing that, let's go on Mentimeter again. Can I see the Mentimeter page? Just to say that this is not just another meeting, another forum, another conversation that leads nowhere. We want you to be comfortable with all that we're sharing with you. But if you leave this room in the afternoon the same way you walked in, then we would have failed. We want you to be disturbed. We want you to be unsettled. We want you to get uncomfortable about the way things are, and we want you to be excited about the opportunities that we would create in this room. So it's important for us to understand what this is all about. My country director pointed my attention to the fact that we're all wearing this stuff, and I'm sure some of us didn't even notice that there's a QR code behind the tag that we're wearing. So for those of us who are not using Nokia 3310, you should be able to scan this code and it will take you directly to the present slide that we have on. The instructions are still on. Once you scan it, it takes you to the slide that you should have. I don't know why this is what it is still showing. So there are a couple of things that I wanted to point our attention to as we bring Dr. Fatima on. Okay, so you're moving the screen closer. Thank you so very much, sirs. So we've gone through all of this, yeah? Dr. Fatima will be on in a bit. I was going to go through the series of achievements, but she also has that in her speech, so I don't want to go through all of that. But for those who are not too familiar with the pre-servicial training institution space, these are some of the statistics, and you can check them on your phone if the screen is proving too difficult. So the very early schools of health technology, the first one ever was founded in 1920, right? 103 years ago. And then the first nursing school, I guess, would be 1949, School of Nursing, LALE, Ibadan. These are like very old schools that are still alive and well. And I'm showing us this to say that we have so much data, we have so much that we have put into the works, that we have done over time, that we can actually learn from and begin to even get better, beautiful results from the work that we do. Please, once this comes on, I would bring Dr. Fatima on, and we would take it from there. I'm resisting the urge to do something that I should do, but I would do it nonetheless. I'm the one that has the mic right now, so I'm controlling things, yeah? Okay, so good. So I mentioned at the beginning that I was not going to be calling names and I was not going to be pointing attention to people, but I've done that a few times. I would still have the honor of bringing a couple of more people on the stage. But just to acknowledge the presence, and I know we've done a very high-level overview. I don't like news. You should remove this AIT. It's scaring me. I don't like it. Okay, so, but more seriously, yeah, can we just celebrate the presence of, I will still put doctor in front of your name, Ogaima, Dr. Emmanuel Oguchi, as the Logistics and Commodities Program Manager and Alternate Task Order Contracting Officer Representative. Very long title. Well, Ogaima, please, can you just wave, let the people see you? Please, let's put our hands together for him. He's part of the USAID team, and he provides immense support to our program. In the same team, we have, since I'm a doctor, I'm just giving people doctorates today, so it's allowed. Dr. Chukwuemeka Nwachukwu, USAID Washington, please can you just wave to the house? Thank you so very much. Because I've been giving doctor, I will add an extra doctor to Dr. Sylvester's name. So Dr. Sylvester Akode, I'll still go to introduce him much later. Please can you wave to the house, is our main man within the USAID team. All right, so some of you know her as Nana Girls. She's well known within the space. She's going to reel out our portfolio during our presentation, so I won't go over that. Please, with a loud ovation, make warm welcome to Dr. Fatima El Adam. Thank you so much.
Thank you. Okay, yes, I can see my.
Can we have the Mentimeter on, please?
So this is.
Yes, so advanced. Let's try this point in there. Yeah. Again. Great. All right. Thank you.
Thank you. Okay, good morning, everybody. I'm also not good at protocol, so I'm going to observe all the names mentioned and those that have not been mentioned. It's a really pleasure for me to be here and to give the keynote address. I'm really opportune to share with you my over 10 years, probably 15 years, experience engaging and advocating for increased production of especially nurses and midwives. Okay. So this is really my presentation. I'm going to, of course, look at what are the production challenges. I try to pick some areas, and of course, what do we need to do, or what has been done to address the issues. So I'm so glad I have the regulatory bodies, leadership of the regulatory bodies there whom we have worked together extensively. And then what are the opportunities, and as well as the recommendation. So let's start with the introduction. My interest on HRH, and especially the production side, really has a long history. Of course, in 2009, under an FSCDO project called PRINAT MSCH, and I was in charge of the demand side work. And each time the supply side, each time we visit the community, they complain about nurses, midwives. You know, there are no health workers in our facility. And I said, oh, what is the problem? Why can't we be producing them? Why aren't they in the facility, especially the PSC facility? So I decided as an academic to really do some work. And I was really amazed the issue we have. And I picked some of the quotation. And so what we did, we interviewed both the nurses and midwives and their husbands. And this is one of them saying, no matter the incentive, my husband would not permit me to go to the rural area. And the husband said, having incentive may help, but I do not think any husband will allow his wife. And no incentive, that's another midwife said, no incentive will compensate for my children's education. There are no good schools in the rural areas, and I will not go there. Clearly, clearly there is an issue. So producing them is not enough. So that's one example. Of course, I have another experience under Women for Health, which I was then the chief of party or the national program manager, and we operated in Borno State, Jigawa, etc. And of course, there is also the Girls for Health. They are all on production. And then I was the convener of SURE PMCH. And that was really, in fact, it was shocking. All the, under the MSS scheme, we really tried to address the equity and posted people in all the PHC facilities. And suddenly there was crisis, the conflict, the issue of the conflict. And all of them left, many of them left the PHCs, and they all went back. They left actually the north and went back to the south. So all of this, it became very clear to me that, look, we need to work with the community, we need to work with the government. Government needs to take up that responsibility, and especially the state government, because the MSS was a national program, and then so the state government will have to take up the responsibility to produce their own health workers. There was just no shortcut about it. And of course, and I think I would stop here because I'm very conscious of time. But these were all each one of them has something. Another one was this girl. I don't want to show her face very well. So this was a girl, as part of our work. She was just 14-year Fulani girl in Katsina State. She delivered. She had difficulty with delivery, and we had to take her to the hospital. The husband divorced her because she was attended by a man. This young girl, because she was attended by a man. So all of this really made me to realize that, look, we need to work on produce our own health workers. And of course, we all know it's no longer a news, and it's a global problem, that there is shortage. There is shortage of health workers, despite the production. And we can, whichever standard we look at, are we going to look at the National Primary Healthcare Development Agency that says it is for any primary healthcare, it's one medical doctor, one nurse midwife, one SHO, whatever way, or is it the population, the WHO, that look at the population, we need 1.7 nurse per 1,000 population, whichever way we look at it. We are definitely producing below our need. And that is very clear. I look at the production of the community health practitioners, look at it, look at the need, and look at what we are producing. We are definitely producing below. The same thing with the nurses and midwives. It is the same thing. If you look at the number of index places and what is required in the country, we're all producing less than what we need. And that has been the cause. That has been the cause of discussions. It is recognized nationwide. And to make it worse, and look at it, if we were to take the production, our average population growth, I got from one of the government document, is 3.2, but our annual production of nurses and midwives 2.6. Definitely there is gap. And look at even this is the latest data that is available. I could access. So, and production is not only having increased production is not enough. There is the issue of equity. They are not equity, is it in terms of geographical location between the north and the south, and even within the south. So look at, of course, Nesra is in the north. It has 49, almost 50 nurses per 1,000 population. But look at Iboi. It has only less than 8 nurses per 1,000 population. So there is in it. So what I'm saying, it is not, even though Nigeria is producing substantial number of nurses and midwives, for example, they are not evenly spread. So there are disparity within the state. And the same thing between rural and urban. And I don't think it is, it's one of the biggest challenges. It's very common you go to the hospital in the city, you have more than 100 midwives. You go to many of our PHCs in the local government, hardly can a local government general hospital really have a nurse and a midwife. Whereas in a specialist hospital in the state capital, we have a lot of them. So it's not only the production, there is also the equity issue. And another related equity is the need to have, I'm a woman, so the need to have more women as health workers. So, what are the other challenges? There is, of course, the Jaffa syndrome. We are producing them, other countries are taking away. And this is really bad. And I cited the example of statistics from Nursing and Midwifery Council, for example. We produce in 2022, we produced over 21,000, but 13,000, more than half, had applied to leave the country. So we are producing them, they are leaving us. Of course, there is weak capacity for planning and management of the little we are producing. In most cases, I'm not sure we have really sat down critically to say, over the years, how many health workers do we need? How many doctors does this country need? And how many doctors in each state need? Individual states are doing that, there is that, and what step have we taken in order to ensure those productions are being done? Such is lacking in many cases. And of course, because of this lack of planning, we are overproducing some cadre of health workers and underproducing some. And it's one of the biggest challenges I have with many of the states we engage with. Decide where the gaps are and really shape your own training institution to produce what you need. There's no need to produce what you don't need, and then you left them unemployed, and you are also looking for another. So this is the really reality. Another one is the political apathy. I'm not going to tell the governor, the state governor. I visited, the last election, the 20, and I welcome, as sort kind of, when you are the chief of party, you need to see the Uga. I visited the governor and I was explaining to him, etc. This is my plan. I'm going to produce how many hundreds of, construct hundreds of PHCs. But I said, that is good, that is fantastic, that's very good. Who is going to man those and provide the services for you? And then he started. I said, no, that's the reality, because it's easy to construct hospital. It's easy. But producing a health worker requires a minimum of 3 years. So you better plan for that, so that before you leave your tenure, you finish your tenure, you have enough to. So if I'm you, suspend this construction. So in most cases, they don't give priority to our pre-health service, to our training institutions, but rather they look at it's about building. And so there is that really. Another important thing is, and that's HWM experience. Many of health training institutions, many of our tertiary institutions in the state, they have autonomy. Is it the College of Education? Is it the universities in our state? They have the autonomy. They budgeted and give them their money to decide what they want to do with it. They are responsible for the recruitment of their teachers, but not the health training institution. Even though they have been made a college, and which that should have given them the autonomy, but yet they are yet to be given that autonomy. So I don't know, and as part of the HWM, Nana is one of the implementers. I was saying, then if you can give the College of Education that autonomy, you can give it to them. I was asking the commissioner, why can't you give it to the health training institute? So I think somehow the political class seems not to link the health training institution with the delivery of health service in the state. And I think there is that gap that needs to be bridged. Okay, quickly, I'm very mindful about what are the health human resource for health production challenges. Of course, one issue is about admission. This regulatory body, in order to ensure quality, had really set aside some quotas for each training institution. And one thing, because there is limited investment in those health training institutions, they tend to over-admit. So even though they are given, let's say, 100 space, they will admit quite maybe 500, 300 minimum. And there is some change in some, because I've made some call with some of the health training institutions, there is some improvement. But generally that is, even if not there, in terms of selling of application form, thousands will apply. And this really created a disharmony between the community and the health training institution, because that is the assumption. You talk to people as an NGO, we engage with the community. They said, no, those ones, they are cheating us. They're not, because they have seen that many, they will apply, they will be there, and majority of them will drop out. And that is not good for the system. And again, the inequity. As I've said, and I've given some of the quotations, we can do all the planning, all the management we want to do. At least for the northern that I know, northern state that I know, majority of them will not leave their cities and their children to go to the rural area with their children. That is the reality. Even if they, and I'm sure that I've seen some of the PAMSET and directors here, even if they post them there, they will always find the way to come back. That is the reality. So the only way out is really in our own system, admission system, to set aside admission slot for those rural areas in order for them to produce their own. And we have that experience. Engaging with the community, please produce your own. Are you expecting a husband to bring his wife in order to service your own wife? If you don't want that, then you better produce your own. And communities are ready and are willing to do that. But you know the way it is. The admission, the form, immediately it was open, it is done online. The many of our rural areas, they don't even know when it was open. It was a matter of two days, it's closed, and they missed that. So we need to address this issue. In order to ensure that we produce, not only produce adequate, but we also produce for those who are in need of it. So, another big issue around admission is the issue of the pressure. Many parents, you know, some of us in the north, many of our religious leaders are really preaching for people to go into health training. For people for us to produce our own health workers. But because of that, parent, and I'm sure the provost here, parents do put pressure on their children to go into that. And in most cases, we have so many cases where we have to resolve. And the children, that's not their own interest, and that creates problem and wasted space for others. The same thing with some nepotism in terms of pressure. If you ask some of them here, they will tell how much pressure they go into during admission. In fact, I was talking to one of the provosts. I wanted to get some data from her. Her phone was off. I said, what is it? She said, you know what, I have to switch off my phone because I was under pressure. You know, so they are not allowed, and that creates problem, affect the graduation rate of the student, and it is a wasted investment on them. So the same thing in terms of examination, and I see my brother here looking at me recently. We were just working PAM. They have introduced computer-based exams, and the students were panicking. They have never, they don't know, they have the skill. They don't have computer skills, and here is the exam is coming was it at that time? It was in a month's time, and some of them, they come to our office, we have to teach them how to do it, and the school, we engage some of the school to do it. So this is the reality. And of course, I'm not blaming the regulatory body, because that is the reality and that's the best way to address the issue of malpractice. But then, of course, there has to be a system of the student. Of course, the regulatory body had taught the teachers, but then they have forgotten the student. I don't know, or they didn't forget whatever, but then there is that serious gap. And again, there is weak, and that's related to that, weak student support structures. Look, is there any study group? I said about the CBT issue, and there's no counseling, and we have so many cases. Some of them, from my experience, they are in school because their parent, I've seen a case because their parent insisted on them coming to become health workers, and the husband would take another wife. And psychologically, emotionally, find it really difficult to cope. And in that cases, and this is the reality of our life. And what I'm saying that the system, if the system, they know that is the reality, what is the school doing to address this challenge? And you have to be giving counseling, and that is really required. And there are little, I'm not sure, except USID and, for example, an FCDO, there isn't really few funding opportunity for disadvantaged students, especially for the community health. Because in most cases, in many of our states, once you get to that, there is an allowance, so that's better. But for the community health, they struggle very hard in order to achieve that. I think I'm very mindful. Another is the learning environment. This is really a serious issue. The infrastructure, the teaching aid. I know the government is doing its own best. All I know, the regulatory bodies, they will not compromise on that. That's one I know from my experience. They will not compromise on that. So it's very important for the government to really make that to make that provision available. And also, of course, I know, for example, HWM is supporting with the teaching aid, for example. What is more disheartening for me is the issue of the tutors, the instructors. That is a big, big challenge. And they are not adequately, and unfortunately, many of them will leave, and they don't have the power. That's the pre-service health training institution. They don't have the authority, the autonomy to recruit. The recruitment process still follows the civil service rule, at least the states that I'm familiar with. And there is embargo on employment. Whereas, as I've said, the universities, they are free to do that. There's no such thing. But our own, the PSHCI, there are those in embargo. And that is really, really very critical. And for example, in the last year, the work by HWM in Kebbi State, for example, there was 129 gaps of tutors in the 7 health training institutions we work. At the same thing in Sokoto that we did. So what I'm saying, this is really a serious, and this is very important, especially as the colleges are transiting to collegial system, wherein they need more teachers, more qualified teachers than before. The same thing, the delivery of the curriculum. We still dogmatic, teacher-centered. There are so many efforts, I know, to make it student-centered, and HWM is really working very hard to improve that. I know also Women for Health did a lot in that direction, but more needs to be done. Okay, we just, this is in terms of capacity challenges. For example, last year, in the training institution, where it's how many of you have really receive training that is related to your teaching, not general training. I know we have the CPD, but related to your teaching. And this is really in terms of the competency. And this is what we get. So they have been trained, for example, in terms of examination. They have mentioned the regulatory body had in terms of even how to operate the CBT. All of that had been done. But in terms of to improve their own teaching competency, we are a bit slow on that. And another thing is really poor incentive for tutors. Anywhere you talk, because they are not autonomous, so they follow the civil service rule. In most cases, promotion is done, but it's not accompanied by the incentive related to that. So there's no such incentive to do that. I mentioned the outdated curriculum, and I really want to take about, in terms of the need to improve the soft skills, in terms of communication, empathy, and our work we did under the HWM, they're very, very good and very excellent in terms of the content, the academic content. But it is in terms of the soft skill, the issue of empathy, the issue of communication, the issue of teamwork, the issue of leadership, that is really a bit weak. And we need to do more. And that is probably, I'm sure, when you're engaging with the patient, especially with the women, one of the things they will tell you, one of their challenges is the attitude of the health workers. And this is probably is linked to, because that is really, we need to do more in that direction. So what is being done to address all this? I've said a lot, so what has been done? So I'm really picking, as I've said, the regulatory bodies are doing their best. I know, for example, the Nursing and Midwifery Council of Nigeria had done, have their own strategic plan, and which they are really working, they are following it to implement, and I'm really impressed with that. And then, of course, also, in order to address the production challenges, for example, there is the introduction of the community nursing and midwifery programs. And in my discussion with many of the probers, and they have all been now, in many states have enrolled into it. Now they have 2 annual admission cycle. It's a semester program, so they have what they call 2 streams. When we started with this work, when I started in 2013, for example, there was some, I don't know what reason, but private sector weren't allowed to open training institutions. The community health started it earlier than the nursing and midwifery. But what is important is that it's open now, and so initially it was only state government and missionaries. But now that is open. In fact, I remember even to struggle to get the federal FMC, they wanted to open, but finally that was approved. So what I'm saying, there was some restriction some years back about who should even have such type of school. But I'm so happy that has improved. Of course, now because of the transition to collegial system, so now we have even degree and diploma. Importantly for me is the digitalization process that is taking place in this, and that has really greatly improved both the quality of the teaching as well as the professional practice challenges that really happened earlier on. So what is USID, for example, support in all these challenges, areas of challenges I mentioned? For example, in terms of admission, there is support by HWM in area of identify some of the challenges and putting some mechanism in order to improve that. In terms to improve learning environment, as I've said, there is the procurement of teaching aid, as well as supporting the health training institute to mobilize resources. The reason why this resource morale is very critical, there is the goodwill. Somehow, at least, and I'm sure, in fact, even in the south, in the northern part of the country, and I'm sure in the south, somehow many religious leaders and the community see health as some of the things that you get in the hereafter. So people are really ready to support and invest. And so once there is really good support, I'm sure the health training institutions are really working very hard. And I've seen some of them getting some type of private support as a result of this. And I can mention KB, for example, and the rest. Tutor capacity training, I think I'm not going to, I really like the Tutor Connect by HWM. That has been mentioned. I don't want to, and I'm looking at my time. Yeah, so what are the opportunities? As I've said, there is high demand for pre-service health training, workers training. You know, you all know that. And the reason, I don't know the reason, there are so many reasons, but one of them is once you graduate, especially for the nursing and midwifery, there is automatic employment. in the state we work. So that is really an incentive. And in most cases, I mentioned the issue of they provide scholarship or allowance opportunity. And there is this, every family wants to have a health worker. I'm sure we all came from families, we know how that is. It's really a source of pride that you have a health worker in your community. So let me quickly, I'm looking at, I have just 3 minutes. Let me quickly look at the issue of the recommendation to government. I mentioned that attitude must change. We know we must attach value and invest on our pre-service health training institution, as we're doing with other tertiary institutions. And this is my call to the government, especially at the state level. That is not being done. And we also need to get the balance right between technical and political engagement. I said production is not only technical, it is also political, because there has to be that commitment. And I can give you an example. Okay, I don't have that. So the same thing, we need to address the governance issue in the health training. One of the big challenges, you talk to the governor, and I talked to a governor about it, I've talked to a commissioner. There is, you know, they know that this health training institution are collecting money from admission, from selling of forms, thousands of them, etc. And hardly, they don't know what they are doing with it. So why should the government put money, since they are already generating money themselves? And I said, don't hold them to account. Is that the reason why you should leave the system to suffer? So we need to work on the governance issue about transparency and accountability in our health training institution. That is very, very critical. In terms of development partners, I tell you, from my experience on Women for Health, it's investment you need more than 3 to 5 years. From my experience, a minimum of 8 years before you get the result. And I'm really telling you, when we started Women for Health, many of the training institutions, they do not, in fact, if I can recall, Yobe and Zamfara, they were not even producing. They were closed by the regulatory bodies because of certain challenges. But now, when I was calling them, no state is producing less than 500 now. They have index number 100 for basic midwifery, basic nursing, community midwifery, and diploma. All the states that Women for Health supported, but at the beginning, FCD, they are not sure of this investment. They are not sure, but the result is now there to show. And this is really for me, and I'm happy that we have USID here. Really, it will be a wasted, it will not be a value for money. If we just do 5 years and we close HWM, it's not value for money. You need more than that, because it's a systemic change that has to happen, and it will happen. I have seen it with Women for Health. Also, engagement. Engage with everybody, and I think that is really very clear. We need to leverage on technology. The same thing with the private sector. I can see I have only 2 seconds. The same thing with the private sector. We need to work with them and ensure they invest and provide the CSR, the corporate social responsibility of our companies. They should come to the aid of some of these intentions. I'm happy. I know HWM, we've heard that we're working on the scholarship in order to provide that. We need to intensify our policy advocacy, reach to the governor, challenge him, because they also need, that is the only way to get things done. I think I have no time, but I felt HWM providing scholarship in some of it, and I felt, let me try to give some of the testimony, and because of time, I'm not going to. But it's what is interesting for me. There was a woman, a widowed, her husband died, and she felt she was advised the best way for her to look after her husband is let her also go back to school, and she would advise her to go to the nursing. That was in Kebi, and she went. But then she was struggling to pay for her son, for her children, school fees and her own. She was in the last year. Many of those that they are in their last year, they almost withdrawn, and we have to bring them back for them to, and this. So in fact, I was touched by some of their testimony, and that was why I really feel the need to provide school. And these are people who cannot afford. They are not my children. They are not your children. They are children of those that really cannot afford, and we need to provide, and we need to ensure that they do that. Otherwise, we'll continue to talk about this issue of HI, who can produce as many as we can. The reality is, majority of our women will not go to the rural areas. We need to mobilize the community. And Nana, we have done it. Communities right now are funding some of those, one elite like me will say, okay, we will look for you if you are from that town. Okay, can you sponsor this girl? And people are doing it. So let's work with the community. Let us support them to produce their own health workers so that we will resolve this problem of inadequacy, especially in rural areas. Thank you very much.
Great. Dr. Fatima, thank you so very much once again. Thanks for, we could hear your heart in all that conversation that you had. And I could pick a couple of things which would reiterate on as time goes on. I think we've been sitting for quite a while. And recently I read something about sitting killing faster than smoking and all of those kind of dramatic research results. Yeah, but I think we should lighten up a little bit. The next phase is the panel conversations. And like I said, this is the phase where we want to get you uncomfortable in your seat, because we want you to think about these things and not just think about them, but begin to make decisions that will alter the narrative that we have within our country. Media guys, we have to get this down before I bring the boss on. But I wanted us to see something to lead us into that conversation. Can we have that video now? Should I help you with this? Okay.
You okay? You need a minute? Cool. Okay. Listen up, people. I know a thing or two about extinction. And let me tell you, and you'd kind of think this would be obvious, going extinct is a bad thing. And driving yourselves extinct? In 70 million years, that's the most ridiculous thing I've ever heard. At least we had an asteroid. What's your excuse? You're headed for a climate disaster, and yet every year governments spend hundreds of billions of public funds on fossil fuel subsidies. Imagine if we had spent hundreds of billions per year subsidizing giant meteors. That's what you're doing right now. Think of all the other things you could do with that money. Around the world, people are living in poverty. Don't you think helping them would make more sense than, I don't know, paying for the demise of your entire species? Let me be real for a second. You've got a huge opportunity right now. As you rebuild your economies and bounce back from this pandemic, this is humanity's big chance. So here's my wild idea. Don't choose extinction. Save your species before it's too late. It's time for you humans to stop making excuses and start making changes. Thank you.
Sure, sure.
Poor power supply. And then we have lagging behind the poor attitude on the part of students. I think the students are the ones voting largely here, right? So you're pointing fingers, right? Who wouldn't blame other people? Anyway, but the good thing about this is that we all agree that these factors actually do contribute to the performance of students in the schools. And we also did conduct a couple of surveys, which results you see here, top on the list. People strongly, over 70% of people strongly agree that across board, poor power supply, accommodation issues, poor sanitary facilities contribute highly, and fewer people disagree to that. And regarding tutor competencies, and we're showing you this because the conversation that Dr. Akande is going to be leading right now as he calls on his panelists is centered around these two themes. We see a lot of people, these results you're seeing were self-reports by the tutors themselves. And across different themes of effective teaching strategies, classroom management, you see a lot of people with no knowledge and most of them with basic knowledge. Of course, some of them have some form of analysis and application competencies. I would not want to bore you further because there's so much to talk about. So we would leave this out. Let's just have the counter on and hand over to my chief. Thank you.
Thank you so much, Dr. Emmanuel. If you agree with me that Dr. Emmanuel has been doing a fantastic job so far, would you please put your hands together for Emmanuel? Okay, so good morning, distinguished ladies and gentlemen in the room, and to those who are online. Allow me to just observe already established protocol. And to start with, I want to really commend the organizers for being deliberate about having the students and their tutors in the room. So there's an adage in Africa which says, you do not shave the head of a man behind his back. And I think in this regard, they've done extremely well. So if you wouldn't mind, let's one more time celebrate the students and their tutors who are in the room with us today. All right. Over the last few years, particularly 3 to 4 years, Nigeria has taken on what I consider to be some of its boldest reforms yet in the health sector. And that's all in a bid to transform the country's health systems into a high-performing one, so that the narratives around poor health outcomes can change. But for us to realize the potential of these reform efforts, there is a need for a competent, productive, fit for purpose, and fit to practice health workforce. And the foundation for this is actually pre-service training. However, the reality, as you've seen, both from the Mentimeter and the presentations we've had today, including that very brilliant one by Nana Girls. Sorry, I'm not calling her exact name, but I think she's Dr. Fatima, but we all know her with Nana Girls. She's done an excellent job with that. But the reality is that majority of these pre-service health training institutions do not have the kind of environment that inspires effective learning. And their tutors do not get adequate support, that would allow them to function optimally. And so the panel today will be focusing on better understanding the root causes of these challenges, but more importantly, coming up with what we consider as practical solutions to help change the narrative. And so if you would, I'd like you to join me in welcoming these esteemed panelists to the podium. I'll be starting with Mrs. Rakia Saleh, who is the provost of Aliko Dangote College of Nursing Sciences, Bauchi State. So please make welcome Ajia Rakia Saleh. Also to the podium would be Mrs. Grace Amadou, who is the coordinator of midwifery at the Usman Danfodio University Teaching Hospital, Sokoto State. Please welcome her to the podium as well. You could take this way as well. Yeah, let's shorten the travel time. It's also my pleasure to welcome Dr. Johnson Diarra. Dr. Diarra is the provost of Sudan United Mission School of Health Technology in Ebonyi State. It's also my pleasure to welcome the registrar of the Nursing and Midwifery Council of Nigeria. I'd heard Dr. Emmanuel describe him as a digital registrar. So please make welcome Alhaji Farouk. I was expecting the folks from there to give us like a digital clap or something. Right. And last but not the least, that will be joining us physically is Alhaji Bashir Idris, who is the registrar of the Community Health Practitioners Registration Board of Nigeria. I'm sure Alhaji Idris has a name that has been given to him by HWM, and we'll figure that out before the end of the day. I understand Dr. Sodzi Tete should be joining us online. Dr. Sodzi Tete is a regional director with the Institute for Healthcare Improvement. Is currently in Accra, Ghana, and will be joining us online. Can someone please confirm if Dr. Sodzi Tete is online? Okay, if he's not on right now, I'm sure he is. All right. So Dr. Sodzi Tete, we're happy to have you join us, and you're welcome to this panel. So, a very good morning to you, esteemed panelists. I think we've had some very good foundation laid this morning with the presentation from Dr. Fatima, as well as the very brilliant comments from Miko McKay, HPN's office director, and Andy Omoluabi, the HWM's chief of party. I'll be starting with Dr. Diarra, who I understand has had extensive experience working in both private and public pre-service health training institutions. As a matter of fact, he has superintended over those institutions. And This is a general. If you open any dailies in the country or you care to read about learning environments, you'll probably hear something along the lines of the learning environment in most public institutions in Nigeria have been described as very poor, inadequate, and not conducive for learning. From the Mentimeter, it's clear that physical infrastructure, hostel accommodation, power supply, sanitary facilities, and the likes are often an eyesore. What do you consider to be the root causes of this problem?
Okay. Thank you very much, Sylvester and the audience. You're welcome. Actually, I would like to take a background. You know that when it comes to the demand supply for health in this globally, it looks like a pyramid or a cone. But when it comes to Nigeria, it looks like an inverted cone or a pyramid because of the plume in the curative service. So when you are talking about the issue of infrastructural deficit in our institution, it starts from the policy level, at the government level, the appropriation itself. You discover that much is not actually appropriated to health. And even when you come to the health, how much is appropriated for the infrastructural deficit that's been for a long time? We are clapping our hands this year that the health budget of the country has really improved, been 8%. But you still know that when you look to the business day after the budget presentation, it said Nigerian 2023 health budget, big in paper, but light in implementation. So it shows that most of the time, even the little thing that is given to health, when it comes to execution, the bottleneck that are involved in pulling it out is another problem. And even when it gets to the area where it will be used, how judiciously are we using those money? So when you look at the whole thing, you discover that it's from the policy level to the execution level to the point of use. So these are the major problems that I will see are the things that are dragging us back when it comes to the root cause of the problem we have in our institutions. I think I'm not taking much of your time.
Right, so if I hear you well, it is poor government funding,
yeah,
as well as perhaps the prudent use of the resources that are made available.
Yeah.
And I can lay credence to that. So sometime last year, I visited a training institution in Kebbi State. I will mention this particular one. And I've got to say that to say I was impressed is an understatement. Everything seems to be in place. Wonderful hostel accommodation. They had everything that you would be looking for in a training institution. And I was curious to understand why. So I took a look at the state budget. And lo and behold, I found out that that particular institution got 80% of its funds released in 2022. Little wonder they were able to do the things that they were doing. But that's not all. The other individuals I spoke to, particularly the Commissioner for Higher Education, also mentioned that they had very strong leadership. And she alluded to, the wonderful management, that is available in that particular facility. Conversely, I visited another facility. I won't say the state this time. And the perimeter fence was down. It was a school of health technology. There was no fence. This is an institution that has like 80% females. There was even no gate. And also I got curious. I looked at the state budget, and that particular facility had less than 30% of its funds released in the year in question. So that, basically speaks to the fact that government funding is very critical, but also is the management of those resources. Because when we speak to the government folks, part of the reasons they give us as to why they are not very keen, on, and maybe not rightly so, not very keen on disbursing funds is because they cannot guarantee its expedient use at the health institution. But thank you very much, Dr. Diarra, for that. I'll be moving on to Ajia Rekia now. So Ajia Rekia, yes, we understand the importance of government funding. But here is the truth. And in public health, we're realizing the need to actually move towards what's called a whole of society approach, where it is not just government alone, but we're also having other stakeholders like the private sector, high net worth individuals, development partners, all contributing to solving problems like this. What do you consider to be feasible approaches to crowding additional resources on top of what government is already doing to help address, the challenges of the learning environment?
I think we all agree that the funding is inadequate. The only to partner with the private sector, the non-governmental organization communities, to see how we can mobilize more resources for the pre-service institution. And secondly, in our own capacity, we were able to establish a resource mobilization committee where, with the support of HWM, we develop what is called organizational capacity assessment tool to assist the individual institution to identify their most priority needs in the institution, and another tool known as institutional strengthening costed tool for us to advocate. And recently, with those tools, we are able to identify and contacted some philanthropists and NGOs, and they are willing to support, because the ISP, when you present to the partners or the people that are willing to support, they are able to see the cost, what they can do, and instantly they can say, I will be able to do one or two things. And another thing, it is time for all the pre-service institutions to look inward. One of the way we are doing is we are planning, it's not on ground, to upgrade our ICT to a jam center so that we can be using it to get some revenue. And secondly, for the teachers, resources are very inadequate. They also need to be motivated. So we try to establish a cooperative society where tutors can contribute and invest so that it will take care of their own welfare. And secondly, apart from those, we also try to use our ICT to establish some courses which we can award a certificate of attendance in computer operation tailoring. Since we have now joined the MBTA, and all schools that have joined the MBTA has to have an entrepreneurship center. And these are some of the ways. There are lots of plans that we have been doing with the help of the health workforce management that have assisted us to identify ways we can mobilize resources. And we also intend to upgrade our school clinic in collaboration with the state primary health care to a health center so that the community will gain from us and will be willing to contribute to us, and that is still on process. These are some of the things that we have been trying to do, upgrade certain things that can be utilized. We identify some conference halls, we rent it to educational program, more especially when it's related to health. It is good for them to do in an environment of health training institution. So we also set up a consultancy unit to take care of that. And for us, even though I don't know whether your next question is to see how people will be willing to donate, we also have some mechanism to check whatever we are doing. I don't know, should I continue?
No, that's fine. Thank you very much, Ajarikia. So Ajarikia is saying that feasible approaches to crowding additional resources might be to reach out to the private sector. And I like the fact that you're not doing that on an ad hoc basis, but you're getting that done through the development of a deliberate institutional strengthening plan that identifies where those weaknesses are, where you want to get to, and when you approach these high net worth individuals and entities, they can then identify areas where they can support. Is that correct?
Yes.
All right. I also like the fact that you mentioned that the schools are now looking inwards to see how they can generate funds themselves. So entrepreneurial approaches where people can pay to learn those things, and having a hall that folks can rent. But that sort of ties me back to what Dr. Fatima mentioned. She talked about autonomy for schools. And at the moment, have you got autonomy in your school to go ahead and run endeavors like this? Or when you raise these funds, it's still being asked for at the level of the Ministry of perhaps higher education or somewhere else? What level of autonomy do you have to use these funds to improve the learning environment?
For this purpose, we have gotten autonomy to utilize this thing because there was a time when the halls were rented by UNICEF. You know, before they agree to even utilize the facility, we have to sign an MOU. What are we going to do with it? So we realized all we need is to inform, because we have a kind of a partial autonomy. You cannot be doing things without letting them know. But thank God, in Bauchi State, they will not prevent you from doing the right thing. And when you are doing it transparently, there is no problem. So we utilize the form, construct some conveniences for staff, or reverse some things, and we bring evidences to show what those things look like, and this is where the money goes.
Absolutely. So we can't overstate the importance of accountability, you know, and transparency in the use of those resources, because that is what will attract private sector entities and individuals to contribute to improving our various institutions. Moving on to Alhaji Bashir now. I think we've spent some good time on the physical infrastructure as it relates to the learning environment. But that's not all there is to having a conducive learning environment. There's also a positive psychosocial environment, you know, one that is devoid of intimidation and one that does not bring about emotional frustration. You know, it does help create a conducive environment. Can you tell us, from your experience as a registrar of the board, and perhaps your collaboration with the Ministry of Higher Education across the states, how can we help create these safe and inclusive spaces that will be conducive for learning?
Thank you very much. From the issue of psychosocial environmental factor affecting the school, when you look at, there are mixed reactions, or there are a lot of components in the schools that we regulate their training in terms of their males and females that live in that school. So psychologically, you need to prepare their minds so that they can have a comfortable environment that learning should take place. Take issue of hostels. Are they having different hostels for male and female, or are they living in the same hostel, using the same toilet facility in terms of bathing, whatever? These are factors you need to consider, because maybe I have a wife, I brought a wife to that school, and maybe looking that they are living in the same hostel with male and female. Psychologically, learning cannot take place in that aspect in the schools. And equally, in the environment, in the classes, are they having the same toilet, utilization of toilets? And what is the policy statement in that institution pertaining sexual harassment to students? Is there any documented policy that when it happens, because there should be a relationship between the tutor, between a student and student. So sexual harassment can happen in that area. So what are the policy statement or policy document in that address this issue? Most especially, some student can be intimidated because she's a female, he's a male, he wants to get her, she refused, he can use to pin her down pertaining their studies. Is there any statement that can address that issue? Probably, is there any desk officer or somebody that a female student can feel free to go and say her problem to that? So these are issues we need to consider. And when we are criticizing institutions, what are the policy guide in that aspect of male to female relationship? Both of them are students, female to male tutor or administration of that institution. If there is none, so psychologically the learning environment cannot take place. Then the provision of that social amenity, there should be differentiations in terms of what you can address to a female and a male. These are things has to be considered within the school setting. If not, then psychosocial factors can affect learning, where what we want to achieve cannot get within that institution. These are some few issues we need to address, because we are policy makers. We regulate the training. And when we go to the school, we have to get this in clearly stated in their student handbook, and even in the State Ministry of Health, that anything happening in such on that aspect can be addressed, because already it has been documented. If there is none, then there will be a problem in terms of learning environment in the school.
Right. So, yes, I think it's good to have these policies that you talked about. But just remembering my own days as a medical student as well, I'm sure the school I attended had, you know, these policies in place. But sadly, it was still an environment of some intimidation, where as medical students, you know, you were intimidated by senior registrars, intimidated by some consultants, you know. And unfortunately, for some people, that was what actually pushed them out of clinical practice. because they didn't think that that sort of environment was one that they could thrive. So beyond having these policies in place, I think it's also the actual implementation of those policies. Do the students feel there is a safe space, to sort of make this report where there won't be retaliation? And is there, can they also anonymize some of those reports, where you may not find a name, but somebody is able to come and report up what might be an issue? So can you just give us a practical experience of how you may have resolved any issue that is related to sexual harassment, bullying, intimidation in any of the schools?
Yes, I have a similar case in one of our training institutions. I want to mention the training institution. That issue happened during her project. The student was writing a project, and the project supervisor was a male. What she was telling us that he attempted her and she refused. Then he said she has to carry over that project, and she couldn't write her national exam there. She wrote a petition to the board. We have to send a committee to go and sit down with the school authority and sit down with her to hear her own narration. Very unfortunate. She has recorded certain information with him, and she availed us with that information. And that's why we need that staff at that area. We have to call him and write to the school, sanction him, and that student must be allowed to write her national exam. So these are issues. When we observe that area, then we develop a template. We have a portal that whenever we go for sporting supervision, the student can be able to say whatever they want to say at that time. And sometimes we ask the teachers and the admin staff to just leave us with the student interaction, because we have our VETOs that usually go for supervisions in the schools. Let them interact. Did they have any issues? If they cannot speak it out, they can write. This is our portal. They can write and submit. We can look at all those issues. If there are issues, we call the school authority and discuss with them. So this is a way we feel we can do it. And equally, we encourage the school authority to have somebody that will be addressing that issue, and that issue can be reported to him or to her without informing without the student, the school authority knowing it is A or B that make this complaint.
Absolutely. So yes, it's good to have those policies in place, but more importantly, ensure that it is implemented to the latter, so that the students or even the teachers themselves feel safe to make these reports whenever there is a need. Coming over to you, Mrs. Grace. So the school that you superintend over is located within a teaching hospital. That's not so with many of the other training institutions. Does that confer any learning advantage to your institution, the fact that it is located within a teaching hospital?
Yes, it has a lot of advantages. To mention but few, the proximity actually gives our students easy access and then unlimited opportunity to learn within the clinical areas. The walk between their hostel, the school, to the clinical area is just, depending on the ward you're going to this time around, about like 5-10 minutes. So you see our students sometimes volunteering in the trauma unit, accident and emergency unit. They just walk down there during weekends to help out there, and that is also improving their learning. Sometimes you find the wise ones going to, we have this special posting in midwifery, and then they get to spend just 2 weeks in areas like neurosurgery, theater, ICU. So some of them use their weekends to go walk down there and also learn more. Now, still, it also helps to provide a conducive learning environment, devoid of stress and tension of issues around insecurity, because they run shifts, and sometimes you see them walking down from the hospital when they close around 9:30, 10. So they are actually comfortable because they are within a safe environment. The structure of the hospital actually gives them this biosafety. Even when it's raining, there's the long corridor from the hospital down to their hostel, connecting to the school. So it's well lit. You can walk down in the night without any fear of fall. Even when it's raining, the corridor gives you that shield so that you can walk down. So it actually promotes learning 24/7. And then the students, because we don't have the access to the library in the school. The closing time is 6 p.m. So they walk down to the hospital. For those that are nocturnal animals like us, they read in the night. So they walk down to the hospital. They use the hospital seminar rooms, very conducive to read, and they can always come back home. Another thing we've also observed with that, it gives the tutor the opportunity to also walk down to the hospital to supervise the students, to interact with their preceptors. And then there's this, we introduce them to, because of the proximity, even when we are on block during classes, there's this Wednesday clinical seminar, the O&G department. So we join them at the clinical area. We interact with them. They respect our students. They give our students opportunity to ask questions. They give our students opportunity to also contribute to the meeting. So we also realize that the students like it. So they come on Tuesday to say, what topic do we have tomorrow? So we give them the topic. They read ahead of time because they see it as a challenging ground that they also want to. It's actually very of great advantage to us.
Right. I mean, that's a ton of advantage. So clearly, we cannot move all our training institutions into teaching hospitals. But I'm wondering, is it possible that we link every training institution to a proximate hospital? And is that happening right now? So it could be a health training institution that is not very far away from a general hospital, for instance. Is there any deliberate linkage that occurs right now where every training institution is linked to a health facility, perhaps a secondary health facility, where they can also get this advantage of exposure to clinical learning? Is that a deliberate policy in place right now?
Okay, thank you. Yeah, I know, well, with the Nursing and Midwifery Council, they are very conscious about that. When they go for accreditations, from the few ones I see, they look at that distance. And I also know that, okay, for institutions that the proximity is not close, what they do now, they look for accommodation. For the policy, I can't say much about it, but I know there are ways to actually bridge this gap. Like where we take our students for community posting, the General Hospital Tambuwal, we told them we need accommodation for our students. So the students live there. We also have accommodation to observe them.
Okay,
yeah.
So Alhaji Bashir, I'll come back to you quickly. So for the schools of health technology, are they linked to health facilities where they can get exposure to clinical practice?
Yes, they are linked to. But the problem now only depends with that of the teaching hospital.
Right.
We usually send our students to primary health centers. But you cannot say the primary center has to be linked with the school. Sometimes it depends on the area that PSC has been located. But actually there must be PSC that is linked with the school that students are going for practical area.
For practical learning.
And the school must have a PSC within the institution, so that for proximity. But other ones that they can go at any other time, we don't consider proximity because where they are being located, we cannot say they must be close to the training institution. But the school must have a PSC inside the school that can be used at the training at any time the student wants to learn or two things. Right. And that center must benefit the immediate community. Right. So the community can access healthcare services in that PSC.
All right, so I mean the reason behind that question is to ensure that the students are having exposure to practical, clinical, teachings. Yes. So it's not just didactic teachings in the class, but indeed they can have this exposure. Yes. And I'll come to the digital technology, to the digital registrar right now. Is that the same with the Nursing and Midwifery Council of Nigeria? So the UDUT is a very unique case because they are within a teaching hospital. But are the schools of nursing and midwifery linked to facilities as well?
Thank you very much for that question. Let me clearly say that most of the training institutions, nurses must be linked with the hospitals, either directly inside or very close, because we need the teaching hospitals and other tertiary institutions for clinical experience. So it is compulsory, and there is not only teaching hospital Sokoto that is having or housing the training institutions. Other teaching hospitals are different parts of the country. The schools of nursing are sited inside the teaching hospitals. That is making the environment conducive, accessible, for learning environment.
Okay, so that's good to know. Our digital registrar, this is 2023, and digital technology is changing the way that we learn. How has the council supported the pre-service health training institutions to adapt to the use of digital technology to improve their learning experience?
All right. You see, when you introduce a policy, some institutions take it so lightly, but it had been long. This digital technology has been integrated in the curriculum, making it compulsory for all the students must learn a particular courses related to ICT. And council periodically organize seminars and workshops in order to upbridge the knowledge of lecturers, and also creating step-down training, not only the lecturers, even the student. Just to share with you, when Dr. Fatima was giving an example, when the council introduced CBT exam, students were panicking. But a series of workshops and seminars were carried out, and practically were also implemented. So council put a policy and impose that policy, and all the institutions must comply. For example, it is part of the accreditation requirement. Every institution must have a computer laboratory. And there was a minimum of 25 computers per program, and they must be connected with the internet 24/7, and the student must have accessibility in order to ensure, and all this is imposed by the council. And we make sure that this is carried out, and the student or the school is at the verge of losing accreditation. Failure to do that, now we impose the technology to do that and make sure all our services are technology-based. You cannot access the portal without, if you are not technological, you are not ICT compliant. All the council portal were created in almost all the indexing, registration, licensure, certification, including the exams today. So therefore, we encourage all the institutions must be computer literate, both the lecturers and even the students were enforced on that aspect. And the practical sessions were carried out periodically to ensure, and the council provide what we call support supervision to ensure compliance.
Right. Thank you very much, Registrar. I'm really glad that you mentioned that one of the accreditation standards has to be availability of digital technology. And I'm sure that in itself will force the training institutions to put in place more, or to improve the digital technology availability for the betterment of the students and the tutors. Dr. Sodzi, if you're online. So Dr. Sodzi has had the opportunity of working across several low and middle income countries. And I believe he has gleaned lessons, from his work across these countries. Dr. Sodzi, are you able to just share from your wide experience some of the things you feel we can apply to Nigeria environment to improve our learning environment?
Space, and that will come with heavy capital investment. So many of the governments will struggle. But there are two instances that are aside that perhaps we could learn from. In Ghana, I know that the government set up a Ghana Education Trust Fund. And what this then did was that it ring-fenced the money for all the infrastructure. So you find that in terms of computer laboratories, libraries, hostel facilities, because this was dedicated strictly to education, it improved, the resources in that area. And I think that's something that we could look at. The second thing that came to mind was how in many places in Africa, the secondary schools have managed to get stronger support from the alumni compared to the tertiary institutions. So in many places, you will find out that there's a very structured way in which you're supposed to support your high school. 20th anniversary, 25th anniversary, 30th anniversary, all of them coming with some dedicated type of project or the other. I'm just also thinking that it should be possible to lean heavily on this sort of experience and then take it to the tertiary level so that those graduates, alumni of these various schools can find a way of giving back. I think that's one way in which we can address the matter of the physical infrastructure. You also talked about the psychosocial, and I was very happy to hear about the issues to do with intimidation, bullying, sexual harassment, and all of that. In some places, they would ensure that every year the tutors, the senior management, everybody goes through this type of training. And it's not just something theoretical with case studies, with scenarios, so that there's awareness. Because in some of our settings, even when people are harassing female students or even males, it doesn't strike them as harassment, but that's what it is. So it is important that it is worked into the way things are done, so that it's not just a policy on paper, but then people are actually being encouraged to practice it. There's also the bit about the feedback, where in some places that we've done some work, they would solicit feedback from students on the effectiveness of the teaching and the learning. So they can give feedback about, whether the lecturer was able to explain the concept. All of this is anonymized. And it would really be the duty of the dean or the registrar or somebody to actually go through the feedback that the students have provided as a way of continuously improving the performance of the tutor. And I think that also sometimes tends to change the way people are positioned. And then counseling units. Counseling units is very important when students are struggling with their studies, when they're struggling with subject choices and subject combinations, when they're struggling with life issues, if they're counseling unit is somebody who can advise them on what it is that they're doing. All of these also help to foster a conducive environment for teaching and learning.
Right. Thank you very much, Dr. Sodzi. You've mentioned a couple of practical things that I believe we can take forward. The idea of counseling is very important. I recall I've had the opportunity to have had what they call personal academic tutors, in one institution that I attended. And when he appeared like I was falling behind on some things, that individual had some conversation with me to better understand what the issues were. And then he talked about how our secondary schools have a very strong alumni. And I'm sure most of us in this room belong to several WhatsApp groups. Those secondary school WhatsApp groups are perhaps the most active, right? And once it's 10 years, 20 years, or 30 years after graduation, they take on a project, right, to sort of improve things in the school. I wonder why that can't also be done with the pre-service or training institutions. Some of our graduates have gone on to become commissioners. Many of them are now director nursing, some of them are even registrars. So I think that's one practical, recommendation that we can take forward if it doesn't already exist, where the alumni of these schools can come together to give back to the school that has given so much to them. Dr. Sodzi, before you leave, just a quick one from you, because we're switching gears now to more of tutor capacity. So when we say tutor capacity, what exactly does this entail in the context of a pre-service or training institution?
Well, there are various ways in which one can look at this. I think the first and perhaps the most obvious has to do with the qualification. So in many places they would have clear criteria of what it takes to be a nursing tutor or a tutor in any of these health training institutions. I've learned, for example, that in Ghana, you have to have a master's degree at the minimum. And it should have a research orientation. So either an MPhil or an MSc is what they are looking at. So that is very important. Then there's also the matter of the student ratio. So the qualification focuses on the individual and their qualification, but the student lecture ratio then focuses on the numbers. Do you have enough lecturers such that we can give you a limited number of students so that your impact can be maximized? So in some places that I know, they are looking at 19 students to one tutor.
19.
So
Did you say 19? Did you say 19? 19.
19 is the target that has been set. And then also because of shortages, some schools are set up where they would use a lot of part-time lecturers. And speaking to one registrar in one of the African countries, what they said was that 3 part-time lecturers equal 1 full-time lecturer. So that's how they look at it in giving you accreditation and all of that. Then there's also the continuous learning environment linked to this whole matter of tutor capacity. So what I know is done is that it's tied to your continuing professional development. And it's whatever credits you get are tied to your professional identification number. So at the end of the year, when you go to the Nursing and Midwifery Council, you should be able to demonstrate that you have done a number of courses, you've done a number of sessions, and you have built your knowledge to be able to continue to deliver at a very high level. So these are the things that one can look at: your personal qualifications, your ability to constantly learn, and also the educational authorities creating an environment where you are not overwhelmed with the sheer number of students who should make things ineffective. And lastly, also, it's what I've learned in some places that it's not just the students who keep logbooks. Some are beginning to make it a requirement for tutors to keep logbooks as well. When you go to the skills laboratories, when you teach and students get to the wards, to be able to log that you have taken them through these practical skills so that they can vet the quality of the teaching and learning that is happening. So these are the broad themes that I can handle. Thanks.
Absolutely. Thank you very much, Dr. Tete. So, 19 students to 1 tutor. I mean, that sort of sounds like a tall order compared to what we have right now. Dr. Fatima, what's the current? I thought you shared a figure. What was it? Okay, 1 to 10. But what is the reality across our institutions? I would imagine that sometimes maybe even over 100. But so, coming to you, the digital registrar, and there are many of us who work in the public health space who would crave the opportunity to give back to institutions that have made us. And I know friends who actually are happy to serve as like part-time instructors, teachers. I see Charles is nodding his head. There are many people who would, take on this opportunity. Are you taking advantage of that?
Certainly, that is, we encourage that. I will just give you a reference. FCT Gogalada, I attended a program where the product or the trainee that were trained as alumni of that institution group themselves together, come back to support the institution. I also want to give you another example, UNTH Enugu. I met a group of nurses in California, and they came out with the idea that they learned the teaching, the School of Nursing has lost accreditation. What can we do? I just opened my system and I told them, look, these are the challenges and why the school lost accreditation. And they grouped together to support the institution and supply so many training institutions and the equipment and models. That has also contributed and restored the accreditation status, increasing the quota of the institutions. There's something in one of the School of Nursing in Owerri, Imo State, that's it's a mission school. And also similar gesture was also created. So I think it's a very good gesture. The alumni are also contributing and restoring the glory of that institution with support, with modern equipment, models, and what have been.
Absolutely.
And that will help.
So, meaning we can tie this back to what we had said earlier, that you can have this alumni in place. So they not only contribute in terms of perhaps financial resources, they can take on projects, but also, serve as like part-time tutors. And maybe not even them alone, it's also their contacts and folks within their network. So for instance, if I get approached by someone who is an alumni of, say, IGS College, I'll be more than happy, to serve in that role. So I think that's one area that we can take advantage of. And getting additional people.
If that alumni had the capacity to do that, not all alumni can come back and now.
Right.
Well, exactly, but if you possess the qualities and
exposed our tutors to the most updated curriculum and clinical guidelines and implementation guidelines in the country. I'm sure you're aware that year to year we have updates in, as an example, malaria guidelines, newborn care guidelines. How exposed are these tutors? And just recently, there has been revisions to the curriculum. How exposed are our tutors to these updated policy documents?
Certainly 5 years. And at the end of review, we organize what is called as orientation, implementation strategy for such curriculum. And it is compulsory. All tutors or institutions must send their representation to participate. And we decentralize the implementation curriculum, and we follow the pattern of the geographical structure of the country because we want to make it effective. Each of the geographical zones will have their own, and we also make it even practical oriented. And at the same time, institutions are also encouraged to organize step down in their respective for other tutors that have no participation, so that every lecturer, every tutor become familiar with the
But has this been the practice? Do they really conduct the step down?
Yeah, that has been, and it's compulsory. When you, the answer of the policy you're talking about, when there is any when we have such policies are also added in a revised pattern of the curriculum. So that's making it up to date in line with the global trend. And that's what we do in every time we are reviewing. And make sure this workshop and seminar is carried out, including not only the tutors, including the preceptors and clinical instructors, in attendance so that they become familiar with the current trend, with the current curricula that have been revised at the council. Right.
So for the curriculum, that happens every 5 years. But for the policy guidelines, it can happen anytime. So how do you ensure that those new national policy documents make its way into the curriculum and our students are not being taught what we consider obsolete?
All right, that's what I said. You cannot just review curriculum after every year or 2 years. When you have a policy, we organize a workshop, seminars, where the lecturers or tutors were informed of the new policy, and they were directed to implement it, added to that, and we package it and in preparation in the next review, so that it will now be documented and become compulsory part of the content.
Absolutely. So I think that's very important. So moving on to the registrar of the Community Law Practitioners Board. While Jesse was making a presentation, he talked about the EBSCO library, which HWM is supporting not just your board, but also the NMCN to establish across the pre-service or training institutions. But the truth is, HWM is not in more than 50 health training institutions, and would like to see this, scaled up across, I want to believe, the thousands of health training institutions in the country. And here's why it's important. Open access to academic journals, allows tutors and students to, barrier-free information that is useful to them. Many people in this room went to schools where, they had open access to journals. But today, that's not the case. If you were to go access a journal now, you'll be asked to pay. And those things aren't cheap. And I believe that's what EBSCO, seeks to achieve. So, how do we ensure that we scale up beyond the 50 or so facility institutions which HWM currently supports to make sure almost every institution in Nigeria benefits from an initiative like this?
Part of our criteria for accreditations, after having your library, you need to have equally e-library. And in the e-library, you need to have offline, because some of the schools are located in the rural area where they can have access. And it's mandatory to upload a number of journals and books. Like in health sector, we have a lot of S-office, day in, day out. Recently, we had a COVID-19 S-office, malaria management has been upgraded. So all those S-office must be in the library. And those offline there are a lot of journal and other SOPs online. You need to download for the student at any time they can assist, offline. And there are another one.
I understand that. So the EBSCO that is currently being implemented now,
yes.
How many facilities have access to that?
How many?
How many training institutions have access to the EBSCO platform?
No,
is it just the HWM supported?
I think the one that HWM
right.
is the one that you supported that have the access.
Yeah, so at the moment it's just the 48 institutions being supported by HWM.
They have that access.
I think we need to, extend this.
Yes.
And we may not be able to do that by ourselves. This is where we need the board, the NMCN, as well as the other relevant, institutions. It might be the Ministry of Higher Education and the rest. But the point we're making is we need barrier-free information, to be available to all institutions. And my question to you is, how can we make this happen? Perhaps it's that we need to engage every other stakeholder who needs to be talked to, and find out what it would take to make this happen. But
yes,
I will allow you.
We need to do high-level advocacy to all those other institutions so they can key in. And maybe you are updating our accreditation template. That area has to be captured. It's mandatory for the institution to have access to those areas. So when we make it, so other institutions can have it within a short period of time.
Right.
So maybe we are going to the commissions of fellow the governors of advocacy. This area has to be mentioned for them so that they can support them in their budget. They can address all this issue during accreditation process.
Absolutely. So I think this is an important point that we need to take further after now, because again, like I said, providing a wide range of barrier-free information to tutors and students is really very important, and it would help improve that learning environment. Now, moving on to Mrs. Grace. So HWM launched this Tutor Connect, and I've been privileged to attend one or two of the sessions, and I've got to say that it's a brilliant one. Right now, we're reaching like 400 tutors. I would imagine that there are many more tutors in the country today. But besides Tutor Connect, what other continuous professional development opportunities are available to our tutors across the pre-service or training institutions?
Thank you very much, sir. Thank you.
Thank you very much. Aside the Tutor Connect, I also know that opportunities like that are there during mandatory continuous education. That's the MCPDP we do have, which the Nursing Council, in collaboration with the NAM, usually organize, is mandatory. So, and then because it's attached to so many things, including renewal of license, you get to see people do that. For us, I don't know if for us in Sokoto, Ebonyi, I know we've also benefited from some work done by some NGOs that has to do with effective teaching skills. It has also helped the tutors to build their capacity. And the institution themselves can also find a way of building their capacity, as in improving their capacity based on the lectures we usually get from the Tutor Connect, because the lectures from the Tutor Connect is actually very helpful. Very helpful in the sense that, like in my school, what I do is that I tend to encourage the educators for us to gather in a place so that we use the LCD, we connect, and we learn together. And then I think it's very essential for each head of the institution to take a deliberate effort to ensure that the tutors or the lecturers connect. Thank you.
Thank you very much. So again, what HWM is doing with Tutor Connect is commendable, and I think we need to scale this up some more. So I would really challenge the board and the NMCN, to consider replicating that in ways that, we can reach much more. 400 is a good number, but you can tell that we're leaving a lot of people behind, and they are not getting the most that they can from such opportunities. Dr. Diarra, now switching things a bit. Now, there are modern teaching techniques, right? So you will hear all sorts of things, supportive learning, visual aid learning. You know, these kinds of teachings require training and retraining of our tutors. Most of our tutors are still used to, you know, bringing notes to class. Not many of them perhaps are very used to visual boards and all of that. So what is being done by the school management to bring them up to that point where the tutors can be exposed to current teaching methods, using your school as an example?
Thank you very much. We understood the importance of technology in learning and in teaching, and we know that the teachers, unless they are well built, they will not be able to deliver to the students. So what we did, even having benefited from so many programs of USAID, like Grace said, we were beneficiaries of the essential teaching skills by the defunct MCSP. So, but in recent time, what we did is that we tried to build the capacity of our teachers on the modern teaching innovations and technologies that are needed for students to learn, making them to understand that teaching is no more the talk and the chalk traditional method, but is now based on technology, is now based on new innovations, and is now more of a learner-centered and development of skills and values, not just more of a practical thing, not just the traditional way that we were taught and they were taught. So we try to build their capacity by bringing a digital expert from Enugu. You know, I don't want to mention the name because it may look as if to some advertising the organization. So they grilled the teachers and the tutors and trained them, and also brought in so many other teaching skills that I even never knew of. There is one they call the flip, I don't know how they call it, the flip chart, something that, first of all, students, instead of learning in the class and going home to do the homework, what they do is that they learn at home and they come to the class to do the practical. So it made the whole thing very, very innovative, that you see the students being very, very apt to learn. And also we didn't stop that. Already it's part of the mandatory requirement that every school of health must have an ICT with at least 50 to 150 computers. So, and not only having computers, but computers powered with internet. So anytime the students go to the e-library, they have this access to free internet, and it made the place a beehive of learning activities. We also made it mandatory that every teacher, for you to teach in our school, you must also have a laptop. If you don't have the money to buy a laptop...
Did you buy it for the teachers?
If you don't have money to buy a laptop, you come and take loan, because it's your laptop, it's not our laptop. You know, sorry to say that, but that's what we did. They use it for other things. So, and so many of them benefited from it. Also, there is one thing that we are practicing in our school, which I would like other schools to take a note of, because medical and health education is a practical-based education. For us, it's mandatory. If you must teach in our school, you must also do practical. We must also work in the hospital. We have hospital. You know, so that you don't lose that knowledge and skills and come to the class and begin to teach what is no more in existence. Because medical education and health education is revolving and is evolving every day. It's very innovative. What you see today is not what you are going to see tomorrow, and we have to follow the trend. If you don't follow the trend, then you will not be able to match the technological development that is going on in the 21st century. So these and more are the things that we are doing in our schools. And I know it's also not only our schools, but in other many schools of health technology, because ICT is the in thing now. Absolutely. It's either you are in or you are out. The system will throw you out. You don't need anybody to sack you. The system, the already developed system, it's just like me now saying, I'm not going to breathe. Then the system will throw me out.
Right, right.
Thank you.
Yes, thanks, Dr. Diarra. And I like the fact that your school is already taking those bold steps And I must agree with you that perhaps many more schools are doing the same. But a quick question to both Alhaji Farouk and Alhaji Idris. So is teaching methodology part of the CPD programs that your regulatory bodies run? Okay.
Well, recently, we are commencing our national exam in a month time to come, and we did our geopolitical training on all the people that will participate in that national exam.
Right.
And it's part of the criteria. Even we asked them, the Tutor Connect program, you have to show us evidence of attending that program. It's another added advantage that can pick you, because you are updating your knowledge when you are joining the Tutor Connect. And equally, you have to attend our FCPDV, and it's part of the team, it has to be there.
Very good,
yes.
Very good. So I know there was a time we were discussing about getting CPD points for attending the Tutor Connect. Yes. Alhaji Farouk, where are we with that?
Well, I think they know the challenge. I told them to submit the content validity. That will give us the basis to assess and award the credit on that Tutors Connect program.
Right.
Coming back to the question you have raised, apart from the MCPDP, we have the student-centered learning meant for tutors. We also have the preceptors programs. We also have the e-learning. These are all the concepts that improve the knowledge and skills of the tutors in order to improve their teaching capacity. It is also compulsory for them to attend the MCPDP, which is also run. We have about 19 modules that are on circulations.
Right.
And each of them, including reproductive, medical, surgical, mental health, and all other areas of interest, they can attend and improve their knowledge and skill. That will also go down to improve the learning skill of the students.
Right. So that's part of the compulsory CPD points they must present before they get a real licensure.
Exactly.
Fantastic.
That you must have minimum of 6 credit units for your license to do. And all this kind of workshop, the SCLA, and if you attend any workshop, such a workshop, we award credit unit also. So if you attend, certainly you have a credit.
So there is an incentive to have them attend.
Exactly. That will also encourage them. Thank you.
Then finally, I'm coming to Mrs. Rick here now, because I want to give the audience the opportunity to either ask questions or clarify what they may have heard, and more importantly, also make contribution to the discourse. So, Madam Rikia, it is well known that low morale and motivation and poor motivation can hinder tutor performance. So we've been talking about all the other things, but I'm sure there are things that the tutors themselves would love, to be in place. It might be issues of salary, it might be, like Dr. Diarra said, giving them soft loans for computers. I'm sure they need much more than computers. So how can we turn things around, to improve, tutor motivation and retention? Dr. Fatima talked about the Japa syndrome. Everyone, if they get the opportunity now, wants to move, to a place where the grass is greener. So what is being done in your institution? What have you heard, from your tutors, and what do you think that government should be putting in place to improve the motivation and retention of tutors?
Thank you very much. I think the issues of tutors' motivation and retention is very important, because a lot of things has been heard from the tutors. Like us in the state system, you find out that some of the tutors are trying to leave to the federal government. So the government and the pre-service institutions should look at, the way to motivate teachers by incentives such as lucrative salary, advancement. In the pre-service institution, there are certain things that you can be able to do. Things like promotion is within your capability. We are doing it. A recognition in form of awards. We are organizing in retreats at the end of the year, and we award dedicated teachers during that time. But the most important part is incentives to teachers. And then the
by incentives, what do you mean?
The salary.
Salary. So improvement in salary.
Improvement in salary. And then again, the environment. When you look at the environment, everybody wants to be comfortable before he can give his best. So there is need for the improvement of environment, and then career opportunities. They also need to be recognized in terms of leadership roles and things like that, because you are a tutor and you are stagnant, you have been giving a lot. So they need to be involved in certain level. So I think when we improve our environment, our incentives in terms of salary, and then we take care of their promotion and assign certain roles that can motivate them, I think they can do excellent. But for now, we have statistics of some of the tutors that are also leaving the state. Those that are not able to go outside the country, they are leaving the state's own institution because there is a great difference between the salary from the state and that of the tertiary institution.
Absolutely. Thank you very much, Ajia Rekia. So it looks like we've used up our time for the panel itself, but I'd asked Emmanuel to set aside some minutes so that we can also get the audience to contribute to the matter at hand. Emmanuel, can I confirm that we still have the time to have the audience contribute? Okay, so now we're turning this over to the audience. There may be very poignant contributions you want to make, or maybe questions that you feel are very important that we have not touched on, or perhaps even clarify, certain issues that we may have raised. And this is where I would really love to hear from the students themselves and others that this may have, touched on. So please, can you just signify by a raise of hand, and it just goes straight to the mic over there. And if you want to actually, if you want a particular panelist to address your question, just point that individual out, and they will be ready to do that. Please, you can make it to the mic as well. So everyone who wants to speak should please make it to the mic. All right. Okay, thank you. Go ahead, please.
Good day, panelists. Good day, ladies and gentlemen. My name is Chastini Amadu, and during the survey, the questions that I listed out on things that affect nurses. I'm a student nurse, and one of them I feel was not given much attention to was curriculum overload. Each semester has a particular scheme that's supposed to be covered, and sometimes it's not covered that semester, it's supposed to be taken to the next semester, and there are students that will be able to cover it up probably during the holiday, but there are some students in class who will not be able to cover it up. For such students, how can they be helped? What can be done for them? Because during the council exam, some of those topics come out and they will need to be answered. So that's it. Thank you.
All right, thank you. So we will take on that. So I just, no, not immediately, just to, so that's the registrar. Very well. So please note that down. Yes, please. Yes.
My name is Dr. Ulwan Mohammed. I'm the Executive Chairman of Rochester Primary Care Development Agency. I have an observation that I think, what is the role of NBT in training institutions? I think they should be part of this discussion. Thank you very much.
Thank you very much. Dr. Ulwan, yes, please.
Good afternoon, everyone. My name is Engineer Shehu Abubakar from Hakimin Gomba Foundation in Kebbi State. In response to this, some of the highlighted challenges at Hakimin Gomba, we do three things for health. We have a scholarship scheme that we run from inception. To date, we sponsor 800 students from inception to date. We give them free scholarships, those that gain admission already. We also look at classes in some of the School of Nursing and Midwifery in the state. We discovered that there are some gaps in classes. We constructed 3 classrooms with a total capacity of 450 students. That means each one can contain 150 students. We also, under construction now, we're constructing 66 rooms in a block of a hostel in Jega School of Health Technology. Each room, self-contained room, can contain 20 students. So which means we are providing over 1,300 bed spaces. So we, after due consultations and consideration, we decided that health needs assistance. And it's a non-governmental organization, it's a non-political organization. Just on our own, we decided to support. What we are looking at in future is the teacher-student ratio. We also look at that. It's under research now. We're trying to see how we can intervene in that aspect. So we feel that other non-governmental organizations should also support. Because when you look at the nurse production rate in Kebbi State, before and after our intervention, there are significant improvements in that angle. So we also encourage everybody to give support, not only government, because when we rely on government, the deficit will still be there and the production rate will still be low. Thank you very much.
Absolutely. I think we should put our hands together for the Akimi Gomba Foundation. I can testify to that. I've been to that institution in Kebbi, and I saw the good work that the foundation is doing. And I like his point about calling out to other, high net worth individuals and foundations of like minds to join in this very good cause. Any other question? Yes, please. Ooh,
thank you very much. Good morning.
Let's make it quick, please. We're running out of time.
My name is Nurse Mohammed Murtala Musa, Provost Kebbi State College of Nursing Sciences, Burning Kebbi. Mine is just an addition with, on regards to the issue of motivation. With what Haja Rekia have said earlier on, what I have introduced in my school is we introduced an acceptance fee. Now, I set a committee. That acceptance fee, now after collecting the acceptance fee, we put it into a particular account. Then each and every department, from their departmental registration, they remit certain percentage of that amount into the same account. Then the school on its own part, at the end of each registration, we put certain amount of money. Then at the end of the year, we now calculate and look at how many staff have applied for studies. Then we pay from 50, 60, 70% of their school fees, which I believe that will go a long way, because most of the places you find out that when it comes to supporting staff, the government is not doing much in that aspect. So that was what we introduced so as to help our staff. So it's just an addition of maybe other schools can learn from that. Thank you very much.
Please put your hands together for the provost. So you're from Kebbi, you said. So that's the facility I visited that I talked about. And I didn't say this. That facility had the boss that's been running for 20 years. You hardly find that in many government institutions. For most institutions, after 5 years, the boss is packed. But it just goes to show that strong leadership can actually bring about the conducive learning environment. Thank you so much, sir. I hope someone has documented what he has said, because that's a good practice that we should encourage elsewhere. Yes, ma'am.
Good afternoon, everyone. I'm Christiana Oluwashio. I'm from Miller College of Health Technology, Kuje. My question, if none of the panelists can answer it, I'm asking because I know there are representatives of Federal Ministry of Health here. Now, we've been talking about training, and we are particular about training us to come out to work and all that. But I can tell you that though our health facilities are lacking workers, there are lots of people who have graduated from the colleges of health, schools of nursing, who are just idle, no employment. Please, I want to ask, what is being put in place for us to be absorbed into the workforce after our training? Thank you.
Brilliant question. Thank you. So please, again, in 1 minute if you can.
Thank you very much. I represent Ebonyi State, the permanent secretary, actually. When they presented the data, I was like, I felt bad, because if you had looked at it, they depicted a very poor state for Ebonyi State in terms of manpower, nursing ratio. But what I want to ask, in Ebonyi State, I know that, is it possible to have a paradigm shift in the way we communicate to the authorities that be, especially as per the council, nursing council? Because most times, especially for government institutions, if you come for accreditation and things are lacking, what they usually do, unless I stand to be corrected, they'll just hand over to the school what they need. The actual person that has the powers to implement, in most times, is the government authority, the governor, as it were. So can't we now devise a means whereby the needed things in the schools can be directed to maybe the minister, so the minister can communicate directly to the commissioner. Because sometimes these commissioners are not even aware that these things are lacking in these facilities. I'm quite aware that even my last governor said that a lot of the things that are lacking in the schools, he was not aware.
Okay.
Because the commissioners, while they were scared or what, never passed it across to him. So is there no way that the council can directly communicate to the ministers or to the governors, so that these are things it's not a rocket science thing for infrastructure and maybe equipment to be acquired? That's just my take.
Okay, all right, that's a good question. So I know Alhaji Farouk has one question. I'll pass that to Alhaji Bashir, and perhaps to help you tie it up, is it possible to share scorecards of those accreditation assessments directly with the Governors Forum, that sort of thing, where, governors don't like to see their states, down the ladder board. So where you're saying, hey, we have assessed your facilities, your institutions, and this is where your state currently lies. And this is what you have to do to get them, up the ladder. I think that may be a good point to take. Yeah. But let's switch things here now. Yeah, so please, 1 minute, everyone. We're already out of time.
Yeah, thank you very much, Sylvester. My question goes to JC. We call him JC. He's actually my colleague, my fellow colleague in the medical school. We went to the same medical school.
So you should go back to your school and teach. Yeah.
So I am very particularly interested in what you mentioned about the online libraries that we have, the 100 laptops or desktops connected to the internet. And I'm bringing this forward because Sylvester said something about alumni helping their schools in teaching. And one of the ways we can reduce the tutor-student ratio of 1 to 19, we need to achieve that. We know that is very possible to achieve. How can we leverage the technology we already have to ensure that we have people who are outside of your school who wants to teach, okay, but they don't just want to be physically available in the school? How can we leverage the technology you already have for what we call online tutoring, bringing on board medical people, health people who have good knowledge, doesn't want their knowledge to waste, to bring to bear, a lot of knowledge, a lot of teaching, into the health of school the School of Health Technology. So that is the question I want to ask to JC Diarra.
All right. So Dr. Diarra, take notes. So please, quickly, one. Yeah.
Thank you, my panelists. I'm particularly interested in Nursing Council. My question goes directly to our digital registrar. We learned, or we have heard, that there is movement of healthcare practitioners out of the country by this Japa syndrome. I want to ask, is there any way that Nursing Council of Nigeria and Midwifery can help in retention of our healthcare practitioners?
Okay, all right, thank you. So, so that's to the digital registrar. So, sir, okay. And then for others, we may need to actually write it down. But quickly.
All right, thank you very much. My name is Mr. Francis, Director, EK Foundation for Autism, and also the Vice President of Behavior Analyst in Nigeria. From the beginning of the discussion, I was a bit uncomfortable, not until you mentioned special needs. So my question is, how much are we doing with reference to those who are differently abled? That's one, with emphasis on capacity building for stakeholders, especially for caregivers. Number two, how much capacity are we building with reference to assessment? Because, naturally, when a child is not functioning within the expected boundaries, the only thing that will happen is, let me take this child to my doctor. How much capacity are we building with reference to even those doctors, the teachers in classrooms, and all of that? Thank you.
Okay, so you're directing that at who? To anyone? Okay. All right, quickly.
Good afternoon, my panelists. My name is Matthew Taisis from Ila College of Health Technology, Kuje. My question is concerning the learning environment. Like we have heard the physical factor that affects the learning environment, I want to talk about the psychological aspect also. Because as we have heard from Nana's college, experience from students dropping out because of school fees. So my question is, if the school fees of our institution will be put in place. If there is anything that can be done for these school fees to be put in place. Thank you.
Okay, so I will direct that to HWM. How can we help the students with school fees? All right, please, and then we'll take from Alaje to wrap up. Quickly, please.
Protocol duly observed. My name is Jennifer Iwazobi from Ila College of Health at Kuje. My question is going to the Nursing Council Board. I'm just drawing their attention to this. There are paper documentations that the nurses should work in collaboration with the community heads. But we realize that when our students go to, community head student goes to tertiary health institutions like the general hospitals, there are segregations. It's documented in papers that yes, these people have to learn some of these things from you people. But you go there and you find out that they tell you that these are not for community heads, these are for nurses. So we come back to school and discuss, okay, but there is a documented work here, paperwork here that these people will collaborate with us. So I'm just drawing their attention, the Nursing Board Council, to draw the hospital management board's attention to accept these people and give them the maximum cooperation they need to be able to go out there and identify these conditions, medical conditions, that they will be able to refer back to the tertiary health institution. Thank you.
Absolutely, thank you. And so that's our last question.
My name is Dr. Nuhu Mohamed Mishan, Permanent Secretary.
Please, can you speak up a bit?
Permanent Secretary, Ministry for Higher Education, Sokoto. I wanted to ask my brother, the registrar of the Nursing Council. I happened recently to be heading the probably biggest health institution in the state at the CMD, and probably also providing training ground for more than 70% of the health institution in the state. And I also happen to have more than 500 nurses and midwives under my watch. And I've also always been worried about their promotions. But when we started talking about the MCPDP, I got interested because I know we've always had challenges that they should have their license before promotions are being made. But I also happen to be the host for MCPDP in Sokoto State for the past few years. I'm sure the registrar knows. I'm always worried why is it that it's always confined to that particular MCPDP being provided by the registrar or the council, while in other councils, like the one I'm coming from, there are a lot of other avenues where you can get those points and then you can quickly gather whatever number of points you have to have. I heard him mention of...
Okay, so we need to wrap that question up. So that
I want to know, apart from the MCPDP that is being regulated by the council, what other channels the nurses can get their points for them to probably get their license provided? Thank you.
Right. So, again, because I've got the power of the mic, I'm going to do something different. We clearly do not have the time right now to answer all of these questions. Part of what I hope we can also achieve today is better networking. So we know who the questions have been addressed to. I'm sure in about an hour or so, we're going to be breaking. And I would encourage that everybody who has asked question sits at the same table with the individual you have posed the question to so that we can discuss that. I hope that will be fair. Because in all fairness, there's another panel that needs to come up now, and they've already given us additional 10 minutes. So I hope that would work as well. I mean, we just don't want to come here to listen to each other. We also want to network. So that's exactly what we will do. So I think at this point, I'm going to thank my panelists, for doing justice to the topic, and to the audience who have asked very brilliant questions. A couple of things have come forth, and I'll try to summarize, in less than 2 minutes. So the responsibility of improving the learning environment and tutor capacity is not just in the hands of government. It will require a whole of society approach. I think it is very clear that government needs to do more when it comes to funding for these institutions. We have shared examples of a school that we consider to be a stellar performer, and it is in part due to the fact that they are getting good funding. And I also shared the example of another school who isn't doing so well, and part of the problem is around inadequate funding. But we also heard from the Akimi Foundation of how they are contributing, their own quota as a private sector, to improving the learning environment. So clearly there is a place, for high net worth individuals, private sector entities, as well as, NGOs out there. Of course, we cannot, take away the responsibility of the school management. It's true that you're not getting all the resources you need, but the little that is coming to you, how prudent are you with those resources? Some places, within a year or two, their buses are already grounded. Meanwhile, we just talked about an institution that has a bus that's been running for 20 years. These things don't happen by chance, right? There are deliberate efforts that needs to be put in place by a strong, school management, to derive the maximum potential from whatever resources that they've got. And of course, there's also the place, for the tutors and the students, in just ensuring that the environment in itself is one that allows, for effective learning. You can have very difficult students, just the way you can have very difficult tutors. So clearly there is a place for, both the students and tutors as well. There are a few things that have come up here that I believe we should not sleep on. The idea of having an alumni, right, for the pre-service health training institutions, where they can contribute to the well-being of the school, both in terms of learning environment and also serving as perhaps, like part-time tutors, whether online or in person. And that's to Charles' point. It can be done online as well. And I believe my colleagues are already taking notes of the very important points that have been made here. And I'm sure all of this, will be shared after now. So our time is up. At this point, I'd like to disband the panel and just thank them very much, for all they have done. And of course, thanks to you all. Thank you so much, everyone.
No problem. That was well. Let's keep our hands together for. We should have told them. Okay. So, can you forgive me up front? I know the registrar has to leave now, but can we quickly have a group picture of the panelists? You want them to stay here? Okay. Please, can you just come here? So sorry about not telling you up front. That's okay. Let's put our hands together for them. Mr. Sylvester, great job. My editor is just. Thank you so much.
I'm sure you have released it.
Yes, sir. Yes, sir. Thank you so much, sir. I appreciate it. All right. So, Dr. Sylvester, wonderful job as expected. Thank you so much for handling that. So, I know that we've been sitting, and I said this before, I'm saying it again. I know we've been sitting for quite a while. We're going to be taking a break shortly before we recommence for the panel 2 discussion. But before we do that, I wanted us to have sort of a breathing exercise. Mentimeter? Yes. So you need to pay attention to this, and I'm happy we're seated. So make sure you're comfortable. Please just press enter, okay? And just follow the instruction. Relax, focus, center on yourself. Let's take 5 breaths together. Relax and sit comfortably, and you follow the rhythm, okay? Breathe in through your nose, following that rhythm, and slowly breathe out through your mouth. 1 breath in through your nose. Most of you are not doing it. Yes, you should be sitting. Yeah, you stand up surely. Out. 3 more breaths. Two more. Out slowly through the mouth. And the final breath. In.
Oh, okay, great. Now, to the exercise that will get us moving around, I need you to stand up on your feet. Everybody, please. No age difference. Everybody, just stand up, okay? It's going to be a short exercise. But I need you. You had some writing material on you. I'm going to give you three statements. So this game is called the human bingo, right? This is a modified version. So the first statement I need you to write down is visited all 36 states of Nigeria. If you can put it in your mind, it's fine. Visited all 33 states of Nigeria, has more than 3 children, owns a BMW. Aha. So what you're going to do now is you're going to move around this hall and ask people this question. And the first person to find all 3, right? So you found someone who has gone all 36 states, you found someone who has more than 3 children, and you found someone who owns a BMW. You're just going to cry out bingo, and then we'll give you a gift. Is that okay? So let's start now. Just move around and ask people, have you been to all 3 states? You must note, you must have evidence at the end of this game. Okay? You must have evidence of who has met this criteria. Move around. I know.
More than 4 children.
I know.
You too.
How are you? You still inside this country?
I'm coming to visit you.
When is that? Yes, what? Where?
Your
country office. Yes, Utako.
Well, Utako. So
yeah. Maria. Yeah, we have a program at Ibeto all through next week.
Yes.
Come to Ibeto. I'll chat to you.
Okay.
Here.
Joe, drink with all of this. We'll
tell them to take.
Oh, is this break okay? Do you want to start off?
When they come back, we'll tell them, would the tea even go around anymore?
No, they put drinks there.
Drinks? Okay, so they told the drinks.
Okay, they just take drinks and come and sit down. So maybe the tea break will ask teachers, the students to serve it. Yeah. Okay.
Nice one. But you own a beer. You look like someone who has a beer. You don't have a beer. Let me give you the secret. This one is me. I've got this one. So, I've got 33 states. I didn't say 33 states. 36. I thought you said 33 states.
And then call us back. Make we hurry up and go. People have order. We have closing ceremony for examiners workshop.
Oh my God! I've not done your best. I thought you said thank you, sir.
Have you visited all the taxis?
No. Who is your boss? Who is that your
Sir, I have visited the whole 36 states, but I don't have BMW. That's the issue.
Let's just finish. People have a lot of things.
Okay, I don't know.
After that, your team, people will decide. Let's just finish. We will fast. We will not talk like Sylvester.
All right.
When they make the snacks, they can share.
Okay, thank you, ma'am. All right, let's come back together, please. Let's come back together. Dr. Lee, welcome, sir. Thank you very much. How are you doing? Very well, thank you, sir. To complete the list.
Nobody has BMW. But many people have visited all 36 states and have more than 3 children.
Yes, sir. All right. Please, can we have you back in the room? Let's all reconvene, please. All right, thank you so much for being amazing. All right, great. So, now we're going to have the second panel discussion. And the person that will be leading us in that conversation can we have one house, please? Can I have the Mentimeter on? Yeah. Do we want to reposition this now? Yeah? Good. All right, one house. So, if I read profile, then we will be behind schedule by another 30 minutes. So, and then you have it in your brochure. So I would leave you to read that. But can we make welcome? Different people know for different things or as different things, which is expected. I've been in spaces where the teachers are referring to us, those as someone who taught them or taught their teacher. And so several generations of impact. Can we make welcome Mrs. Aleri Yusuf as she leads us in the next conversation? Yes, ma'am. Yes. So, do I have the Mentimeter, please, very quickly? I'll just walk through it the same way we did with Dr. Sylvester. Our focus now would be on the training curriculum, issues around admissions and exams. And so I'll need you again to participate on this poll that you can see online. So I want you to rate the following statements, and you show whether you strongly disagree or you strongly agree. Curriculum overload adversely affects students' performance in exams. Weak curriculum implementation negatively affects students' examination pass rates. Students owing school fees should be allowed to write their exams regardless of whether they are in school-based exams or national exams. And the final one is pre-service training institutions should have weeding exams to push out weak students from the program. So let's hear what you have to say, and let's see what the people online also have to say. Oh, people are very fast with this one. Okay. So people are strongly agreeing to most of it. We have the weak curriculum implementation ranking very high right now, and some struggle between the weeding exams and students owing school fees being allowed to take exams. All right, so let's keep them coming. We have only 11 persons that have participated so far. And to just lend weight to that conversation is some results of our own surveys where we asked about curriculum overload and weak curriculum implementation, and we can see the overwhelming response around people strongly agreeing to that. We'll come to this in a bit. So let's get the conversation underway. Please keep bringing in the responses. We can go out of here and focus on the panelists. I'll leave Mrs. Aleri to bring on board our panelists. Thank you so very much, and happy deliberations.
Thank you very much. So permit me to stand on existing protocol. For panel 2, we will be looking at the training curriculum, admission issues, and examination processes in our various training institutions. You will agree with me that when we talk about human resource for health, we talk around 3 things: production, deployment, and retention. For this panel, our emphasis is on production. And to do justice to this, I have 3 distinguished personalities that will be responding to some of the questions that will address the issues around production of quality human resource for health in Nigeria. And so, ladies and gentlemen, please put your hands together for Malam Usman Garbayabo. He is the acting provost, Sultan Abdul Rahman School of Health Technology, Gwadabawa, Sokoto State. You are welcome, sir. Next on the list is Mohammed Murtala Musa. He is the provost, Kebbi State College of Nursing Sciences, Burning Kebbi, Kebbi State. A round of applause for him as he comes to the high table. Next on the list, I want to invite Mr. Lekarex James Kwali. He is the Director and Principal, School of Nursing and Midwifery, Gwagwalada, FCT. A round of applause for him as he takes his seat. Next, I want to invite the Director of Nursing Education from the Nursing and Midwifery Council of Nigeria in the person of Mrs. Margaret C. Eze. A round of applause for her as she comes to the table. Next, I want to invite the Director of Education, Community Health Practitioners Regulatory Board of Nigeria, in the person of Mr. Emmanuel Fajuku. Please, a round of applause for him as he comes to the high table. And last but not the least, we want to welcome the principal, Solina Group, Dr. Muyi Aino. A round of applause for him as he joined the distinguished panelists. So let me assure you that we will try to work with time. For my panelists, please, you will go straight to the point so that we can answer all the questions we have. When we talk about the production of quality human resource for health, the place of the training curriculum is very, very important. And because of its relevance, it is necessary that at all times the curricula are revised, they are updated, and they are made use of in such a way that the users will find it both user-friendly and also able to address the concerns. So in view of the relevance of the curriculum in the training of health workers, I want to start with you, Director of Nursing Education. Given that the curriculum gives you the professional foundation and the transferable skills that you need to function, how relevant and up-to-date is the current curriculum being used by the nurses, the Nursing and Midwifery Council of Nigeria for its training institutions?
Good afternoon, audience. Thank you very much for that question. Talking about the relevance of the curriculum. The curriculum is relevant, or something can be said to be relevant if that thing is appropriate for the time, the period, or the circumstance, or if it serves a contemporary interest. I believe that the curriculum for the training of both nurses and midwives produced by the Nursing and Midwifery Council of Nigeria is very relevant. I say that because of the following reasons. The curriculum was needs-driven. It was based on the needs, health needs of Nigerians that the curriculum was put together. Before it was put together, there was sort of scanning of the environment. Stakeholders in health were involved, including those who teach students. Letters were written to them ahead of time. Ministries were involved, and states were also involved to bring in their inputs in areas that I think should reflect in the curriculum. Again, the curriculum that we use now captured most of the contemporary issues in health. We are in a complex society. Technology is rapidly advancing, and we have to bring in all these aspects into the curriculum. For example, we didn't have a course known as nursing informatics in the previous curriculum. But this time around, taking cognizance of the advancement in technology, we have incorporated that component because it will speak to the electronic health records that is the norm in hospitals now. That aspect has been captured in the nursing curriculum. We talk about the contemporary society today. We know that when people pass out of the university, job is a problem. We have included subjects or courses like entrepreneurship in the nursing curriculum. If you are a nurse, you pass through nursing, you come out, and there is no job handy. With the knowledge and experience you have, you can start up something. We know also that nursing today is moving away from typical hospital-based nursing into people having to be nursed in their homes, in the privacy of their homes. So we took that into consideration, and we have come up with a course that is called Home Health Nursing, giving opportunity for nurses to have in-depth knowledge about nursing people in their homes. We know that people that we produce will go beyond the shores of Nigeria to go and practice. So we have recognized courses such as transcultural nursing. They are now aspects of our curriculum. We talk about quality improvement and patient safety. We have incorporated such components in the curriculum to make sure that issues of quality healthcare improvement are also covered in the curriculum. And besides, the curriculum that we develop covers all the three domains of learning. Talking about the knowledge, we talk about the understanding of concepts pertaining to nursing. We talk about the psychomotor, which deals with the skills acquisition of the nurses. Talk about the affective domain, which also talks about the attitudes. And above it all, the curriculum that we have now was developed within the framework of ICN, International Council of Nursing. It's an agency of the WHO. They have identified 4 strategic directions for nurses and midwives. That curriculum took cognizance of those 4 strategic directions for nurses and midwives. They have, top on those 4 directions is education. They have job, they have leadership, and service delivery. Talking about education components of the 4 strategic directions.
We'll come back to that.
Okay.
Thank you very much. Yes. So please, Mr. Fajuko, can you let us know how relevant is the current curriculum that is being used for our community health workers?
Thank you very much. Audience, good day. Curriculum, we all know, is used in training of students. Curriculum for community health practitioners in Nigeria is so current and regular. It was newly reviewed 2020. No, it's not 2022. It's okay, it's okay. 2022. And it addresses current medical and emerging diseases in the country and re-emerging. And the curriculum provides basis for monitoring and evaluation of education process. It also states clearly the levels of knowledge and skills to be acquired by practitioners. Then also, the curriculum also give learners the ability to recognize the purpose of their learning in the country. It is current and relevant. Time will not permit us to be extracting what the curriculum contains, but it's reviewed currently and it's current, and that is what I'm putting to use throughout the whole country for the 3 cadres. That is junior community health extension worker, community health extension worker, and community health officer. Thank you.
Thank you very much. So from the responses, we are told they have tried to look at current trends, current medical issues, and it has all been incorporated into the current curriculum that is in use. So, Dr. Muyi, in your opinion, how can we improve the quality of our curricula to ensure it meets health sector needs? Because it is one thing for us to say we have put everything in the curricula, but it is another thing to meet the health sector needs. So what do you think we can do? How can we improve the quality of our curriculum to ensure that it meets health sector needs?
Can people hear me now? Okay, this is better. Thank you very much, madam. Good afternoon, ladies and gentlemen. I think that greetings to my esteemed fellow panelists. It's very interesting that all of you are, I feel privileged to be sitting here because these are all leading educators and policymakers in the education sector and administrators and regulators. I'm from the other side of the market. I'm a consumer of your products. One of the big things that we do in Solina is really hire a lot of young, fresh products and work with them, groom them up to do many things. But also, a lot of the programs that we implement, there's a big workforce development, capacity building component to it. So we interact a lot with your products in the field. So I'm sure you will understand if my views are more from the perspectives of a consumer. I think it's very heartwarming to hear a lot of the recent effort that has been put into improving or making up fit for purpose the curricula in our health workforce training institutions. I think from a end user perspective, there are things that we think can be developed. Again, recent changes that you've made will probably there will be a lag time before we see the impact of that in the product. So again, some of what I'm saying may be already in the works. Please pardon me. But I think from what we see in a lot of the products, and this is across, whether it's the medical school products, to lab tech, to nursing, to community health workers, these issues cut across. I think there are opportunities in the content, but also in what it appears to be the mode of delivery of the curriculum themselves. Content in terms of being evolving and keeping up with the evolution of the space. Again, Madam, my co-panelist did mention some of the effort to expand the curriculum into technology, into data systems and things. I think one of the things I will encourage is what the world has moved into, is more application of knowledge. I think there's very little that I know that anybody that has a phone and Google here cannot find out on the internet in a few minutes. The difference is really how I'm able to apply that information to my day-to-day work and to decisions that I make. So I think to the extent that we think about our curricula as building people who are able to apply the information that we're giving them. I think we have a legacy system that is built on just knowing a lot of things. And for a long time, as a health worker, you were a citadel of knowledge on your own, and that's what stood us apart. But in reality, it's all free, available on the internet now. It's really what you can do with it that really matters. Which then brings to my second point, which is how we are delivering the curriculum. It is, the didactics will always be very useful. The old teaching methods are very necessary, but I think to the extent that more applied platforms take a more central role in the training, especially in a sector like ours, where you're training people mostly to go and do things, to go and save lives in the field. To the extent that all the programs sometimes we do know, and we've gotten this feedback as well, and some of that is beyond the educators themselves, is even the capacity of the practical platforms that they have. So many of the institutions are affiliated with hospitals, are affiliated, we know, but you have more students than you have capacity to actually absorb as much clinical training as you will. Is to try to make sure we balance that a little bit. There are a few other things, but I'm getting a signal to wrap up here. So it's to make sure that the content is fit for purpose, but is more focused towards application, not just knowing, because any deficit in knowledge can be filled very easily with technology and the internet. It is more, how do you apply knowledge in what you do? Thank you.
Thank you very much, Dr. Muyi. So, we have to continue to look at the content. We have to continue to look at the mode of delivery. We have to keep on sharpening the skills of the health workers, because nursing, community health work, medicine is all about doing. So it's not about theory only, but it's more about doing. So that takes us to the next question. The issue of integrating theory and practice. The issue of bridging the gap between theory and practice. And I will want Malam Usman Garbayebo to respond to this question. How effective is our current balance of theory and practice in the curriculum that you are using in our schools of health technology? How effective is the balance between theory and practice as a rider to what Dr. Muyi just talked about?
Okay. Co-panelists, distinguished ladies and gentlemen on the opposite, a very good afternoon to each and every one of us. Well, production of marketable or competent healthcare workers is very critical to the nation's attainment of the universal health coverage and realization of the Sustainable Development Goals on health. This is against the background that this category of health workers form the bulk and are at the forefront in healthcare service delivery at the grassroots. So how this can be achieved depends on the training curriculum. The curriculum has to align to the realities in the modern world. The only solution is that a balance has to be stricken between theory and practice in the training curriculum. Let us know what it means to create a balance or strike a balance between theory and practice in the curriculum. Striking balance entails aligning learning outcomes and assessments. What are learning outcomes? Learning outcomes are statements that describe what a student should know, do, or value at the end of a module or course. And assessments are methods or tools that are used to measure how effective students, how effectively students have achieved the learning outcomes. So by aligning the two, we can be sure that the course content, assignments, and the course contents, assignments, and activities are accurate, coherent, and meaningful for both theory and practice. So how do we achieve this? There are strategies, of course, with which you can know that there's a balance between theory and practice. I'll mention two of these strategies, which you can use to judge whether the balance is stricken in the curriculum, in preserving health institutions. One of the strategies is that to integrate theory and practice throughout courses instead of treating them separately, one after the other. That is, you teach, then you take students practical. You teach, you take students practical, instead of teaching, leaving the practical aspects of the curriculum till end of the day. So we can do this. And we can do this by using case studies, scenarios, and simulations. These are very key in integrating theory and practice. We use case studies, simulations, and scenarios, exactly. Secondly, we can allow, or we can provide the students. We can provide them with achievable actions. We can allow them to reflect their potentials. And we can allow them to reflect their potentials so that at the end of the day, they can demonstrate whatever they had learned in the class. Because the issue is that no matter the knowledge you impart on a student, if that knowledge is without skills, then the aim is not achieved. So these are some of the strategies that can be used to create or strike balance between theory and curriculum. But the problem actually lies with implementation. Because the balance had already been stricken in the curriculum, but the implementation is what matters. Because there are instances whereby a teacher covers just half or a quarter of the syllabus and leaves the rest uncovered. Some time back, in my own institution, community health department staff requested that they conduct second semester examination. Then I asked them a question: are you sure tutors had covered all aspects of course contents? They said yes. But I had to prove that. I went around myself, collected notes, handouts, notes, and copy of the curriculum, and went through. What I discovered at the end of the day that some had covered only 30% of the contents, some had covered 50% of the content. Then I approached them. I said, you have been calling, that you have been requesting for permission to conduct second semester examination, but this is what is on the ground. Then how are you cater? And there's one very serious aspect, that is deviation from curriculum, which could be due to incompetency on the part of tutors. Because I discovered that some tutors had deviated from the course content, from the curriculum.
Thank you very much. Thank you very much. So, if you want to integrate theory and practice, from what he has said, first, look at the learning outcome. What exactly do you want the students to learn? In your learning outcome, it will tell you the theoretical things they need to know and the practical aspects they need to know. And therefore, you need to look at how you can harmonize the two so that none suffer at the end of the day. And it's very, very important that we all take note of that. So that takes us to the next question, and I will want Mr. Fajuko to respond to that. How can we better integrate theory and practice into the curriculum as a rider to what Malam Usman Garba has just said?
Thank you very much. This can be done through continuous review of the curriculum. We shouldn't give a gap. It's known that curriculum should be reviewed every 5 years. If it's left on review at the end of the 5th year, a lot of things can be, happening. Then we identify the learning needs of the students. There's need for us to, what do we think that it is the need of these students? What do they need to know? Then the other one is practical demonstration as teaching, and should be used for courses that require skills. Practical demonstration should be used as skills. Then we need to involve experts in the review of this curriculum. Thank you.
Thank you very much. So from what he has said, we should understand that our curricula must be dynamic and subject to change at any time. And that takes us back to the first panel, where the question was asked, if we have new information, what do we do as regulatory agencies and as training institutions? And I know the registrar of the council stated that you are allowed to make addendum. It is used as an addendum, whatever the new knowledge is, whatever the new thing is, the new concept is. So we should know that our curriculum should not be static. We should always give room for amendment. He also said we should always know the learning needs of our students. What are the learning needs? And then we must ensure that our teaching goes hand in hand with demonstration. That is why during accreditation, we insist you must have a skills lab, a demonstration room. Allow the students to go and practice, and then send them to the hospitals or whatever clinical area you use, so that they will still go and try their hands. And there must be synergy between all of you that are in the school and those that are in the clinical area. That is the only way we will be able to get that good collaboration and be able to integrate whatever we teach in the school with whatever we want the students to learn in our various training institutions. Thank you very much. I will still come back to you, Mrs. Eze. My colleagues from the school, I have your own questions coming. We are talking about interdisciplinary learning. And we know that it encourages students to reflect critically on every new idea or issue they encounter, considering it from multiple perspectives. So, how are we facilitating interdisciplinary learning in our curriculum, especially the curriculum of the Nursing and Midwifery Council of Nigeria? Mrs. Eze.
Okay, thank you very much for that question. When we talk about interdisciplinary learning, it refers to the learning that involves two or more disciplines in the training of teaching learning experiences of nurses and midwives. And in my own opinion, nursing by its very nature is an interdisciplinary field. Why do I say that? Nursing takes care of human beings. And we have this concept in nursing, we say is concept of total man, total care. When somebody is sick, you can't take care of if the leg is the ailing part, you can't take care of that leg without taking care of other parts of the body. And for you to take care of the leg, you must know about the structure of the leg. You must know about the function of the leg. So while you're doing that, anatomy is coming in, physiology is coming in. You have to talk about how that person is interacting with the environment. You have to talk about mentally how the person is coping with that illness. So you see a lot of other disciplines are coming in. So that is why in the general nursing curriculum, you have so many courses that are not core nursing courses. You have behavioral sciences, you have pharmacology, you have anatomy, you have physiology, you have nutrition, you have everything, all the courses that are interrelated. And this is why, you say nursing is interdisciplinary. And in the preparation of the curriculum for training of nurses and midwives, all these and even the pedagogical approaches, they take into consideration that interdisciplinary nature of nursing. And in institutions, we try to encourage students not learning in an environment that is solely for nurses. For example, in the universities, courses are taken with other students. When they take courses with other students, you bring them together, ideas, there is a changing of ideas. They learn from other students, and other students learn from them. That is what we are encouraging in interdisciplinary education. Even when they stay in the hostels, you make sure that nursing students are not just all by themselves. They are mixed with people from social sciences, people from sciences, people from other fields, so that there is that cross-fertilization of ideas. They learn from them, they learn from nursing students also. And we're encouraging schools that even in the delivery of the courses in the curriculum, they must not only be delivered by nurses talking about delivery of nursing curriculum. You will invite experts in that field, because when an expert is taking a course, it is not the same thing as when a non-expert is doing it. I give you an example. We have a course in the general curriculum that is called Nursing Ethics and Jurisprudence. If you want to teach that course, you cannot expect a nurse to handle that course effectively without involving a lawyer who will come and apply that law that is his area of expertise to nursing. And it makes it, and the nurse will be understanding whatever is being taught from the concept, from the position of a lawyer. So when you now, come out to apply it to your patient care, it's kind of you're drawing ideas from the various disciplines where you have gathered the knowledge. Thank you.
Thank you very much. Thank you very much. And you will all agree with me that because nurses and other health workers have like 3 roles: independent role, interdependent, and dependent roles. There is no way they can perform those roles if from the stage of training there is no collaboration. So we must begin to train our students to see the need to respect each other in the entire health team, to work closely with the people in the health team. It is through that we will be able to at least prefer quality care to our patients. Thank you very much. So I'll come back to you again, Dr. Muyi. I know. What do you think we can do to foster more interdisciplinary learning and collaboration? You have been working with health workers, different types of health workers. You have seen how they have been working. You have seen how they have been relating. And I'm sure over time you have thought of ways that possibly, if their training curricula had addressed 1, 2, 3, possibly some of the issues you are seeing on the field today may not be there. So what do you think we can do to foster that collaboration among the various disciplines?
Thank you very much. I think underlying collaboration in any environment is really the issues of mutual understanding and trust. For you to collaborate effectively with somebody, you have to understand, you have to trust them, they have to understand you, they need to trust you. That's what it is. So I'm very glad again to hear some of the attempt at expanding the scope of the training beyond the core areas. I think one part that we find missing in many of our products is the issue of management skills. We have a health system where, and I'll get back to your specific question, we have a health system where we health professionals are the managers of the system. And I don't think many people will argue if I say we have not done a great job, if you look at, the performance of the system. So there's something to be said for our ability to make decisions and manage things. And I think that goes back. So when we think about interdisciplinary, I think nutrition is good. I think anatomy and physiology and all of that and ethics are good. I think we need to look outside of health. There are issues of politics. How do you influence policymakers if you can't speak their languages? Finance, because lots of people have to run institutions and be financial managers. So I think expanding the curriculum, as has been said, beyond core health, not just the specific training of whether you're a nurse or you're a lab tech, but just outside of health broadly, that's one. I also do think 2 other things. I think the involvement of non-health workers. She gave the example of lawyers teaching ethics. I think this is a great one. One of the opportunities that I see that is not well tapped in this country is the use of adjunct faculty. There are many people in the room that are professionals that would be very happy to give their time free of charge to share their experience and share their skills to students. I think to the extent that we can look in the sector and what the health sector, especially the public health sector, has done better than the health training component is bringing people from different backgrounds to actually work. Because again, we are finding that with shortage of health workers, you want your health workers to be health providers. So you pull in people from different places to work on health programs. I think there's a lot that can be learned from that. Again, going back to the earlier point I made around just broader application as a component of the training, I think to the extent that students are able to go out and spend a substantial portion of their time in the field. Again, one of the things that I've mulled around is why won't the Nursing and Midwifery Council or the Community Health Workers Regulatory Authorities partner with an MPHCDA, for example, where your students are deployed across the country to the field. You know, they need health workers. They have a platform to train. You have students that are eager to learn. You know, of course, there will be things that need to be worked out, but you know, things like that. Of course, again, the policymakers have to be bought into that. So I think if those are some of the thoughts that I have that I think can really foster understanding beyond your immediate core area of expertise, but also trust for people that don't have your training. Yeah.
Thank you very much. So let me just add to what Mrs. Eze had said earlier, just to clear your mind on some of the issues you raised. I am aware that in the curriculum for the nurses, you have a course they call management and teaching that talks about leadership, management, and everything. You also have a course we call politics in nursing and health industry. And then there is health economics. So those are all things that have been introduced in the curriculum just to give a wider picture and ensure that the nurses are all rounders when they graduate. I'm not too sure of the content of the curriculum for the so it's the same thing from what Mr. Fajiko is saying. So I think we have started a journey, and it's a journey we will keep traveling, following the lane, and I believe we will get there gradually, one step at a time, one day at a time. So the next set of questions I'm sure will interest our students, and especially our keynote speaker, because she spoke extensively about that. And that has to do with the issue of admissions into our various training institutions and examination issues. When our keynote speaker was making her presentation, she talked about over 2,000 forms sold to applicants, about 200 admitted, and the quota is only 75. So at the end of the day, some students are sent away. And this, from her study, has caused a problem in some communities. So, Malam Mohammed Murtala and Mr. Lakarex, two of you will respond to this question. You will agree with me that a fair and transparent admission system is important if we want to talk about the production of quality human resource for health. So, what can we do to improve fairness and transparency in admissions into our pre-service health training institutions? I start with you, Mr. Murtala. How transparent is your process, and how can we improve on that?
All right. Thank you very much for giving me this opportunity. Really, actually, the issue of admission is a very great challenge to almost most of the health-related institutions. And this is as a result of the high demand of health workers. Now, when we're talking of that, usually there is the issue of politicians coming on one side, and at the same time also trying to look for the best students to select. And just of recent, what we did was, after much challenge with the politicians, we now have to introduce the CBT exams. And with the CBT exams, we have a cut-off point, just like the JAM. Then the House of Assembly, they said, no, why should we introduce that? We said, yes, because we are looking for the best students. So they said, okay, what will happen to their own request? We said, yes, we are still trying to set a standard. Therefore, we have to work with that. And now what we did was, apart from setting the cutoff point, immediately the student finished the exams. As you click submit, your score will pop up. You will see, then you move to the printer, and you print and you collect your results. Then you go home with it. So at the end of the day now, when we look at what is the average percentage, then we select the cut-off point, then we invite them for interview. Now your score at the CBT will be 50%. Then the other 50% we look at your comprehension, your reading skills, general knowledge, your character, and others. Then at the end of the day, we select the best. Now, still, sometimes we also have the same challenge again. Someone having below cut-off point, and still the politician insisting that we must give him admission. But we tell them no, because we agreed as a management that we cannot compromise and we cannot come lower than that. And that has helped us a lot for the past 2 years. That is what we are doing in that aspect.
Thank you very much. I can imagine the pressure. I can imagine a candidate collecting her results and going back home to tell the parents, see my result, I failed. You know they will not say that. So, but I understand the pressure, and I think the CBT has really come to your rescue. Mr. Lakarex, what do we have in your school? How transparent and fair is your admission process?
Thank you. Thank you very much. Give me the microphone. Okay, thank you very much for giving me the opportunity to be amongst the panelists. First and foremost, issue of transparency and issue of fairness in the context of subjectivity and objectivity, I think is a measure that cannot be measured. In FCT School of Nursing, if they measure 50% cut-off marks based on fairness and based on transparency, maybe School of Nursing Sokoto, theirs may be different. So issue of subjectivity and objectivity comes in this aspect. To answer your question, in FCT, let me categorize measures involved in order to improve fairness and transparency. I can group it into 3 different categories. First, before the admission process. Second, during the admission process. And third, after the admission process. What comes in before the admission process? A criteria has been set that this is the criteria for admission. We give a criteria, we said so age, you must be 17 years of age, you must acquire 5 credits, passes in English, mathematics, chemistry, physics, biology, you must be indigenous of so place, there must be a quota for all the 36 states, example FCT, with FCT. So all those criteria must be there, laid down. People must have been informed in Nigeria. These are some of the measures before. And first and foremost, we advertise admission forms or online admission. We give a gap, at least minimum of 2 weeks or minimum of 3 weeks. Let it reach to the grassroots of all the people in 36 states. If it is issue of fairness and if it is an issue of transparency. And we try to make sure that it is affordable and accessible. The forms that everybody can be able to afford the form at a stipulated price. Not minding the status, not minding the class of individuals. So that is before the admission processes. During the admission process, what do we do in FCT, College of Nursing? After purchase of forms, we send and categorize. We capture our applicants. We give them numbers. We send their numbers online for them to print. On the day of examination, there are 4 different stages that they pass through in order to checkmate transparency, in order to checkmate fairness, since it is a subjective term. It is not an objective concept. From the gate, there are sets of trained educators that they permit people to come in from the college gate. You show your examination permit slip. We check your passport. Are you the one? There are instances that you will see machineries coming to sit for examinations for people. So these are some of the things to curtail fairness and transparency. After checking, we move the prospective candidates to capture room. We check in the system. Is this the candidate or is not the candidate? Is this the candidate from this place or is not? From there, you move to the third place. Third place is where we do orientation training. Since it is computer-aided examination, we give 5 to 10 minutes training.
So it is the same CBT you use?
That's it.
So when they pass the exam, you do the oral interview also?
Immediately after the CBT examination, successful candidates are being invited for oral interview because there are some things we look at.
Yeah.
During
Thank
the oral
you very
interview.
much.
Thank you very much.
Thank you very much. So in all fairness, we can say that as far as the admission process is concerned, certain mechanisms have been put in place to ensure transparency. But of course, we cannot deny the fact that there are some pressures that these people face, forcing them to maybe admit some people that may not necessarily be qualified. So that brings the issue of sending them out after a few months in the school. Because if you did not pass the exam, there is no guarantee that you'll be able to pass the first 6 months examination. Well, I hope we will keep it up. We will continue with the CBT. We will continue to improve on it. And it may get to a time where we may not even need to do the oral interview. Because you will agree with me that that is purely subjective. But if we really want to be objective, let us do it to the end. Thank you very much. So I still want to ask you, Malam Murtala. In the last session, one of the students talked about the various support services that are available for the students. And you will agree with me, if you want to get the best out of these students, they need to have adequate support services. It will help them to study the environment, every support they need. It will help them to study and help them to perform optimally in the various training institutions. So in your school, how effective are our current student support services, both during admissions and also during examinations? Talking about the internal examinations in the school and the professional examinations that the students write at the end of their training.
All right. Thank you very much. During interview, most of the time when we are going to admit, we pay emphasis to those communities that are less privileged in terms of health workers. We also give them certain percentage, and we try as much as possible to take care of that. So most of the time, after giving them admission, you find a challenge that they cannot pay the school fees. So usually what we do is we have 2 ways there. One, we either collaborate with the politicians coming from that area to see what they can do. Or secondly, now, we liaise with the parents. You now pay installmentally. You sign an agreement that this is what you will do. And sometimes it depends. At the end of the first introductory exam after 6 months, the student performance matters a lot to us. By the time we discover that the student is doing wonderfully well and the parents could not pay, sometimes we give them waiver. We waive them off the school fees. And I remember just of recent, like there are a particular set of students that health workforce paid certain school fees to them, and others were not captured, and which we paid for the remaining percentage of the students, which after that, the next exam that was coming, we've seen a significant improvement in their performance, because by then, before the school fees, as we were disturbing them with the school fees, it was affecting them psychologically. After the school fees was paid, we saw a lot of improvement in their performance, which that has also helped. Then also, at the end of the exams again, we also tried to check which course does the student fail most. Then we identify, we give out survey to find out why was it so. Then we invite the teacher and show him that in your course, why was it that most of the students failed your course? What went wrong? So we try to assess, identify the problem, then the committee is set so that they can talk to the teacher on that particular area to see how we can improve on that. Then we have our counseling services also. They try to identify all those areas, and they talk to the student. And we also, like the Student Affairs Office, we try to create an avenue where that secretly at the Student Affairs Office, they also have some of the students they liaise with. They identify those students that have challenges but they cannot open up. Then secretly they involve them, they invite them, we identify what are their challenges. I think just of recent, we discovered there are 2 students that their father was imprisoned for almost about 6 months and he could not pay the school fees. When we realized that, instantly I said, okay, they should allow them to write an undertaking that they will pay the school fees. Then we allow them to write the exams. After all, the next thing is the teachers contributed and we paid the school fees for them. So this is
very good. So I think we can all learn from Burning KB. You have students that are extremely intelligent, but they can't afford the fees. If the school can give them the partial waiver, or let them sign an undertaking, spread the payment, it will go a long way, so that we don't keep on losing our best because of money. Thank you very much. And I think we should also leverage on the use of the Student Affairs Officer. Like he said, put someone that the students can trust, someone that the students can talk to freely, not someone that has a strong face like me. Let it be someone that when they look at the person, they can freely go to the person and talk to the person and share their concerns and worries. Thank you very much. The last set of questions we will take before we allow the audience to say something is on the issue of examinations. We know there is a saying that exams is not a true test of one's knowledge, but it plays a major role in providing necessary qualities in life such as hard work, patience, creativeness, and leadership. So, Malam Usman Garba and Mr. Lekares, you will take just a minute each to respond to this. How rigorous are our examination standards to ensure the production of qualified health professionals? And after that, I will want the Nursing and Midwifery Council of Nigeria and Community Health to also talk about the exams at the national level. Thank you very much. How rigorous are our examination standards to ensure the production of qualified health professionals?
Okay, well, going by what obtains in pre-service healthcare institutions presently, one can confidently say that our examination processes are not all that rigorous, because in a situation whereby a tutor administers tests to students once in a semester, one cannot say that this is rigorous. And in a situation whereby there are cases whereby students are taken to demonstration laboratories once in a semester, and we all know that the skills aspect of training is very important, it's very critical in producing competent health personnel. Then what can one say in a situation whereby students are taken to laboratory or demonstration or simulation center once in a semester?
So we need to improve on that.
Yes, we need to improve on that.
So from his own perspective, it is not rigorous. That is what you said.
Yes, it's not rigorous.
And therefore, there is need for improvement. If all he said is what is happening, then I totally agree. It is totally unacceptable.
It is not across all institutions. It depends on institutions.
Definitely.
Yeah, and that depends on population. Some institutions are overpopulated, and that contributes, yes, in achieving this.
So in all, I feel the blame is with the management of the institution.
Exactly.
It's your fault that there is overpopulation. It's your fault that the tutors are overwhelmed and they will not be able to perform their function. If you allow students to read without writing exam, they will never read. So I think we need to improve in that area. So, okay, Mr. Lekeret, yes, I will still give you 1 minute for your final words.
Okay.
So don't worry. Mr. Lekeret, 1 minute.
To me, with the FCT College of Nursing, the whole activities is very, very rigorous. We don't give a British space for students. We want, once they graduate, if they are outside, you can easily pinpoint that this is for College of Nurses, Abuja. Holidays is either 1 week in year or 2 weeks. If you take our scattergram, you will look at it. It is full of activities, from doing one thing to another.
No wonder the students were complaining.
From doing one thing or another, we ensure that the intracurricular activities are there. We give small room for extracurricular activities.
Thank you very much. Thank you very much. So we can see we have two extremes, but we need to find a balance. Yes, we need to find a balance. You can't saturate the students with activities and expect optimum performance. That is the truth. So we need to find a balance. Thank you very much. Please, I would want Mrs. Eze and Mr. Fajuko to just talk about the professional, the final professional examination. How rigorous? How do you identify the areas you need to ask to ensure that this curricula that they are complaining that is loaded, that you cover the areas properly and ensure the questions you ask are equally relevant in the current days we have found ourselves?
Thank you very much.
1 minute each.
Yes, the council's examination is very rigorous, both at school level and at the professional examination level. Thank God the principal from School of Nursing, Gwagwalada, is helping us to ensure that at the college, at the school level. At the council level, a lot of steps take place before the final qualifying examination. Texts are developed, what we call a special assignment. We call renowned lecturers and educators, those who are the ones teaching the students. They have covered the different subjects that the students are going to be examined on. They are the ones who come at a special time to moderate questions for the council. These questions are put to test. They are vetted to check their difficulties index, to make sure that they are addressing the curriculum, what they have covered in the curriculum. And then we go ahead to do other things to make sure that those questions are quite commensurate to the level that they are going to test. I may not go in depth into all other things that we do because of the security nature of examination. Now, talking about coverage of the curriculum, I am happy that we have transited from paper and pencil and essay question to CBT. Everybody who has taken computer-based tests will testify that it is quite wide and versatile. It covers all areas of the curriculum. So that is a strategy to make sure that before we certify somebody, we are sure, and if you have passed the professional exam of the council, that yes, you are fit and you are for safe practice. So these are the measures we take. Our exam is quite rigorous.
Thank you very much. Mr. Fajuko?
Thank you very much, Ma. Examination should be rigorous.
1 minute.
But what we put into consideration is we touches all what is in the curriculum. And the general causes among it are being removed when we want to do our professional examination. And before we come out with a question, it goes a long process, from question bank to moderation to selection.
Thank you very much.
What matters most now is that students are not ready to learn any longer. Yeah. Not all. Thank you, ma'am.
Okay. So we have to devise a means of making these students to be willing to learn. There may be reasons why a student will not want to learn. If we go deeper, we may be able to identify that reason, address that concern, and help the student to be willing to learn. The final question goes to you, Dr. Muyi. You have heard of all they have said concerning examinations. In your opinion, how can we strengthen these standards that they have mentioned?
Thank you. I think two things. One quick one on the selection process. I think CBTs are great, and they make things objective and less, and they even spare you, give you, to manage the pressure from people. I think what the oral interviews do in addition to that is try to understand the personality and motivation of the candidate, because in this sector, you need people who are intelligent that can pass exams, but you also need people who are mission-oriented, who want to work in service. So to the extent that, we also struggle with that in our organization. There's a demand to work with us. We recruit people through CBTs, and we're trying to figure out how we can incorporate psychometric testing into the CBT to profile the candidate a little bit and solve some of what you are doing with oral interviews. I think in terms of improving examinations, I think to the extent that we can move beyond testing for information retention, so that it's not just recall of what you've learned, but again also the application of it. I like the attitude of the Gwagwalada team and the Nursing Council, which is you think about the examination as an assessment of your own performance, not just the student. I think you test individual students, but in aggregate, the performance of your students reflects your own quality of training as an organization. So if you think about that as the performance of your product in the marketplace, I think the way you come at it, testing both their knowledge but also their application of the knowledge, and even some sort of post-surveillance, in fact, some periodic follow-up to see how they're doing, and getting feedback from your products in the field might also help you to think about what you test and how you measure. Thank you.
Thank you very, very much. A round of applause for the panelists. I don't know how many minutes we have left. If we have questions, comments, contributions from the audience, I think this is the time. You can go ahead. And for those who are joining us virtually, if you have questions or any suggestion, please drop it in the chat box. Questions, comments, the time is for you. Please just go straight to the point.
Thank you very much. My name is Dr. Charles Alike. I represent Ebonyi State. More like a remark and a question. I happen to have interacted with students from schools of nurses in different schools. And I must confess that what I get, the stress is too much. I'm a doctor, but I've seen a lot of students undergo stress in School of Nursing. And I begin to wonder, are they going to practice in the moon? Is it not in this same world that they are going to practice? Why are you stressing them like this? One, I had my niece. Actually, my niece is a lecturer at Southampton University, teaching nursing students. And I remember very well when she was in school, I used to abuse her, that she's dull. I trained her. But when she went to sit for that, she started, her exam was in Oxford University, and she had the second best result all over the world. But this is a girl that I was abusing. That was when I said that Nigerians are stressing students. How can somebody I said is a dog go to become become the second best student and was, in fact, Oxford University employed her to teach African students before she now went. So what I want to say is the Nursing Council should temper justice with mercy. Let me put it that way.
Thank you very much.
Yes, we need these students to come out. One, a lot of them undergo stress. The stress that Nigeria is undergoing, even workers, they too suffer from it.
Thank you very much.
Students, a lot of them stay in environments when they don't have even light. Water is not enough. The academic environment is not really conducive, but they still try to survive. So is it not time that schools on their own can graduate them? Must the Nursing Council go to stress them that much? I just rest my case.
Thank you very much. It's a comment. I think the general educational system in Nigeria is full of stress. It's not only nursing, but it's noted. Yes, next 1 minute, please. Let's keep to time.
Thank you very much. Thank you. I want to thank the panel. I want to give a suggestion to most of our institutions. If our institutions can go collegiate and then they take the entrance exams through JAM, then that pressure will be off. So try and explore that option. Thank you.
Thank you very much. And that is the thinking of the council. Once you are a college, your admission is going to go through JAM. So once the candidate don't meet the cutoff, the politicians will not come and harass you. At least you have reduced pressure to a certain extent. Thank you. Yes? I will come to your side, or maybe we should, okay, let's finish here. Yes?
Okay. All protocols duly observed. Please, I want to talk about the practical and the theory aspects of teaching. We realize that the theories are more than the practicals. And when we get to the field, what we are expected to do mainly is the practical. Nobody is going to ask you what is anatomy, what is physiology in the hospital. They want to see how you take care of the patients. And most times you spend 6, 7, 8 months in school, then we go for 3 months practical. Can it be balanced? That's the first one. The second goes to the Community Health Board. Now that the Nursing Council is doing the CBT for the board exams, can they just please also let us have the CBT for our national exams? Thank you.
Thank you very much. So please, for the tutors, let's see how it goes, but please take note of the questions. The major question she has raised here is balancing classroom lectures and practical hours. I don't know how your curriculum is, so please, you will try to respond to that. Yes, please.
Yeah, mine is contribution, and I would like to have a contribution in respect to integrating theory to practicals. I want to say if we want to really achieve that, in addition to the points they've given, we need to, after the simulation in the classroom, when we are sending them to the practical area, we should state out our objectives clearly on those things they need to learn in each and every word. And then you should make good use of your preceptors. We've been doing that and it has been working for us. Have a meeting with the preceptors before you send the students, and then don't just leave the preceptors with the students. Go around to check what the students are learning. And we also do this. We have a practical checklist and procedure manual. We always encourage our students to go with it. In fact, we used to tell the preceptors, when they get there and they are not with those materials, please can you seize their phone until they bring it back.
Thank you.
Now, not forget your phone. Then you should not forget those things. And I also want to add quickly to examination. For examination, we've been getting 100% for the past 8 years, and what we do is we try to work around client expectant family projects, and then the project, we ensure that before the final hospital exams, the students are done with that. And then we have removed like a burden of them. Then from January, because the council exam is in March, so from January, what we always do is that we start taking them like classes.
A revision. Thank you very much.
Preparatory council exam, yes. And then we realize that it reduces a lot of things. And then we ask questions like, cancel question exam, and then they answer it, and then we give them feedback from their. Thank you, but I think that will go a long way.
Thank you very much. I'm sure we will have enough time to discuss during the tutor connectors next week.
Okay,
thank you very much. We'll share a lot of experiences.
Right.
Yes, sir.
Yeah,
and then after
much.
him, we will move to that side.
Charles Adeweza is my name. I work with the LHSS project, the USAID project as well. I want to bring to the discussion the experience we've had with financial management knowledge of those who are manning our basic healthcare provision fund. And I believe that these people are graduates from School of Nursing and the College of Health Technology. So we've noticed that with the new reforms right now, health financing reforms, that have developed a lot of strategies and processes of ensuring that facilities are directly financed and they get direct money into the facilities that are handling things for us at the community level. Now there is a challenge that we noticed. The OICs who are in charge, who are graduates of nursing schools, graduates of health technology schools, are not capable of managing those finances. So this is bringing to fore what Dr. Mui had said about the interdisciplinary knowledge. So I want to just emphasize to HWM and teachers, lecturers that are coming from schools here to please emphasize more financial management modules in schools. It's very, very critical right now with respect to the kind of monies coming into facilities. They need to have that knowledge to manage these finances and even manage manpower as well. Yeah. Manage resources, manage logistics, all this
and everything.
Right now as we
Thank you very much. Before I take you, I will take the students. Yes, please.
Good day, the panelists, and good day, everyone. So mine will be a commendation, actually. I really want to commend the School of Nursing, especially FCT School of Nursing, Guadalajara. I really want to commend them. I'm very much impressed about their approaches to examinations and how they vehemently turn back malpractice in our examinations, because it has actually made the students to be very efficient and make them to come out to have this impression that they really need to have it actually on their own. They have to be themselves at all times, that nobody's at their back to put them through in everything that they do. And so I really want to
commend them.
Appeal to the management and the Nursing and Midwifery Council of Nigeria. We are looking forward to more approaches in order to alleviate malpractice and quacks in the community and to improve competent and trained nursing students.
Thank you very much for that observation. And I think I should say kudos to the FCT team. Because for a student to stand in public and commend you, I think is something. We thought they were going to bash the school. Thank you very much. Yes, next person. Thank you very much. So if you have a student affairs officer, I think the person should be knowledgeable in guidance and counseling, or you get a proper guidance and counseling officer. In these days of serious mental health issues, I think the need for it cannot be overemphasized. It's very, very crucial. Yes?
Okay, thank you very much. So again, this is more like a call for partnership. Our NGO was able to secure an influencing grant sometime last year from Oxfam through Voice, and we're currently carrying out the capacity building for stakeholders on special needs education, with emphasis on autism and related special needs. And this time around, the third phase of the training, we are taking it to Gwagwalada. So I want to make an appeal to the Gwagwalada's healthcare workers to be a part of that training, because it's quite important that they understand what the needs are, so that when they see children with autism in the hospital behaving the way they don't understand, they will not be totally thrown off. So, a humble call, sir. I think the Gwagwalada people, I would like to get your numbers to request if that can be done. Thank you.
Please kindly extend invitation to them, and you have seen him, the representative of Gwagwalada, so please see him after. Thank you very much for all you do. Thank you. Yes, please.
Good morning. So I would like to say that if the techniques that of nursing is using is producing 100% result in council exams, then I think other schools should learn from them. Because the last people that came from council got 100% in their council exams. I think the problem is not the exams. What I'm pleading for is that more breaks should be given, please, so that our mental health can be. Yes.
Thank you very much.
1 week or 2 weeks in a year is too small. And then, secondly, about the admission process, I would like to appeal. I don't know how possible this will be, but I want to say it is something I dream to say. I thank God for this platform, and I'm going to say it. If I was waiting for JAM, I would have not been in school today. I think the monopoly given to JAM is too much for me. Can we have another body like WAEC and NECO, that if WAEC doesn't work for me, NECO will work, so that we will debunk the power, so that people can go to school?
Thank you very much. Thank you for your comments. And I just want to remind each and every one of us that in the Nursing Council curriculum, at the end of each semester, the students are entitled to 2 weeks break. I don't know how you are implementing your curriculum, but that is what is there. So please let us consider the plight of these students and see how we can get enough time for them to go and rest. Thank you. Yes, please. 30 seconds. We are reducing the time. We are running out of time. Thank you.
Thank you. Talent something.
Thank you. To create that passion in them for the profession. Thank you very much for that observation. Yes, the last but not the least.
Thank you very much. I just want to, first of all, congratulate USID and the health workforce for all the support of human resource. Please clap for health workforce. The second thing I wanted to say is that I want to disagree with my colleague. He's a doctor and a doctor for almost 35 years. We don't lower standard in any practice. We only improve the quantity and the quality. We don't lower standard. Why the Java syndrome is marketable is because of the product. The product of Nigeria, recently they took 300 doctors away from Nigeria to England. Because the product is good, so you lower standard, we're in trouble. The nursing standard, the medical standard are really standard organizations. Please don't lower standard. Make sure that the government improve the facility, the training, the lecturers, if they can do anything on that. Let me give you an example of pregnant mother. If you don't want to have morning sickness, don't get pregnant. It's part of the process.
Thank you very much.
The pregnancy. So I want to say, the only way we have
1 second.
The only area where I think, and I've been in practice for a very long time, is the board of community health. The private community health organizations are really lower standard. The standards are too bad. When they come for interviews, when they come for promotions, I'm not happy at all. I think we need to look at that standard. But we are not going to lower standard. If anybody doesn't want to leave it, thank you very much.
Thank you very much. I was thinking he was the last, but I can see 2 people. Please, just 30 seconds. Go straight to the point. Our time is gone. 30 seconds. Let me start with you, please.
Okay, thank you for giving me this moment to talk. I want to comment on admission process and share experience on how we do
30 seconds.
Okay, the issue is that during admission, we used to accord percentages. 60% based on merit, 20% a high population area, 20% a priority area, and 10% complementary. The priority area are those areas that are disadvantaged, and we are...
You have 5 seconds more.
Okay.
So what exactly do you want us to learn?
What I want us to learn is to see that it's not only the merits, but when we look at the merits, like say, let's take one local government that doesn't have adequate institution for their people to pass up to 50 or 60. We used to take a passing mark lower than those at the urban area.
Quota system.
Yes.
Thank you very much. Well, that is working for you in your state. Every state should do what works best for it. For me, I think that is my opinion. Thank you very, very much for that. Yes, the student, you want to say something? Please, 15 seconds each. Go ahead, straight to the point, 15 seconds. And after them, please, nobody should stand up again.
Okay, thank you very much. I think mine goes to the provosts and the council. That's the regulatory bodies. I'm just wondering, we can't stop migration. Migration will continue no matter how we try to stop it. But we still need these health workers here. Is it an opportunity for us to produce more and also help in generating more revenue? How do we do that? Possibly these countries that are purging our health workers, is there an opportunity to engage with them? Let them start bringing their own students, being that they have recognized the quality of training we are providing. We can get their own, train them for them, get more revenue, send them back to them, and then our own will continue staying with us, and we will continue enjoying the service.
Thank you very much. Thank you. Over to you, regulatory agencies. Begin to think of student exchange programs. Get people to come into Nigeria to study nursing and pay you in dollars. And then you can send them back. Thank you. Yes, student, you are the last. Thank you.
Actually, this is more, I'm appealing that in terms of all this withdrawal, withdrawing a student based on examination malpractice is quite understandable. But in terms of character and other minor things the student should do in the school environment, I feel like there are other ways you can punish the student. Instead of a student in a final year being withdrawn, and that's why that's why we see most of quacks these days. Because you can't withdraw me in year 3 and expect me not to practice in a clinic.
Thank you for that comment. But always remember, your certificate will say you have been found worthy in character and learning. So let us begin to talk to ourselves too. Why would you, at 300 level, commit an offense that will warrant your withdrawal? So on that note, I want to thank each and every one of you, those that are joining us virtually and those that are in the room. In the last 1 hour or so, we have tried to look at issues around our training curriculum, and we have agreed that there is need for us to continue to explore, to continue to improve, to continue to bring in new concepts, and to ensure that our curricula are covered in our various training institutions. We have also seen the importance of ensuring that only qualified students are admitted. There must be transparency in our admission process, and we must ensure that at the end of the day, wherever we find ourselves, we can stand our own and say, indeed, the students we admitted are worthy of the admission. We have also tried to look at our examination processes, and we have agreed that, yes, there is need for us to set quality questions for our students that will test them in the various areas of learning, so that we can certify that indeed we are producing quality health workers in our country. I want to thank the panelists for doing justice to the questions that were thrown at them. I want to appreciate every one of you for your questions, for your contributions, and for your active participation. Thank you, and we hope we will continue the conversation from here. Thank you very much, panelists.
Thank you.
Thank you, sir.
Can we give them another round of applause, please? So we're coming gradually to this is actually the end, right? Because I don't want some people to say, let me go use the restroom, and then from there they take off. We've heard it all. There are so many questions still running through our minds. The conversations continue outside this room. Great opportunities for collaboration, great opportunities for partnerships, and so we keep taking it forward, and we keep raising the bar. Joanne says, knowing is not enough, we must apply. Willing is not enough, we must do. This is our admonition to us, and I reserve the pleasure to bring to the mic my one and only technical director, Dr. Olufolake Akeju, for the closing remarks.
Thank you, Dr. Emmanuel. Wow, we finally come to the end of this dialogue. Please, can we give a big round of applause to our keynote speaker and to all our panelists? And also, please give yourselves a round of applause for staying to the end. We really appreciate the fact that you could take out time to be here. For those who traveled from various states to be here, we also thank our online audience who joined us and took part in the conversation. We're very grateful that you took out time to be part of this dialogue. This all started with some brainstorming idea in the office. We were just thinking of what could we do around, bringing people together to discuss HRH issues. And, initially we thought we wanted to discuss all of the human resources for health continuum. So right from production to when health workers retire. But then we thought, there's a lot of noise already around the health workers who work within the health facilities. What about the production angle? Not a lot of people talk about that. And so that was what gave birth to this dialogue, and we're really excited and happy that you came and you took part in it, and we intend to write up some articles for all the discussions, and we will share with you. The video for today is also on Facebook. We streamed it live on Facebook, so if you want to go back to watch, maybe there were things that were said that you forgot to take down notes on, you can go back to the Facebook link. So if you follow us on social media, you would see our Facebook link. They are also on the banners. So on all of our banners, you see our Facebook. You see our Facebook and then Twitter handles. But the video is on Facebook. The video is also on YouTube. So please go back and watch to catch up on the things that you missed. And then finally, we have lunch. So please don't go off. Don't run off just immediately. Lunch is next door. So once we exit this room, we'll go to the next room behind for lunch. So once again, thank you very much. A special thank you to USAID. Dr. Sylvester, thank you so much. Thank you for coming. Thank you for staying to the end. And thank you to the HWM team. We all worked really, really hard to make this happen. Thank you to the whole team. Thank you very much.
Thank you so much, man. Thank you so much. So, I know I talk a lot. Don't look at me like that. We still need to take photographs as we get out of here. So, Dr. Sylvester is already packing his bag. But he has to take this. So, please, can I call on all HWM reps? We'll take with the USAID team very quickly, right here. Should we do it here or on the stage? On the stage. Okay, please. Dr. Sylvester, Dr. Emmanuel, please. Let's have you. Chief Andy, Jason, Oga Clep, everyone, HWM, quickly. On the stage. Some people down, some up. Quickly, please. Please, NMCN, ready after this, so that we can allow you run. All right, NMCN, please. NMCN reps, please. Dr. Fola, Dr. Andy, you take with NMCN. NMCN. Yeah, yes. Dr. Fola. Oh, okay. All right. Oga Clem. Okay. Let them come in after this. Let's stay. Quickly, please, guys. All schools of nursing, okay, we should get ready. All schools of nursing, colleges of nursing, you join immediately after now. You join the NMCN after this. Yes, after the ticket. Yes. We good? Are we good? Okay, please. Quickly. Just stay. Quickly, please. All right. Thank you so very much. Community, all schools and colleges of health technology, and the CHPRBN. All schools and colleges of health technology, yes, Oga Clem, and CHPRBN. It's fine. Let them join. Students, be on the lower floor. Please join. While the provosts are on, can we have all partners begin to get ready? All partners, please. Breakthrough Action, CHAI, CC, PRH, all partners. All partners. Tolu. All partners now, please. All right, Ken. Yes, please. You are part of our partners now. Please, 1 minute. Hold on for a while, please. Yes, please. All right, let's have it, please. Oga Clem, join now. Thank you very much. Directors in the house, Ministry of Health, all directors.